君にキュンってしちゃってカラフルに世界がそうなるのずっとそばにいたいの止めないでメリーゴー甘い色を重ねてカラフルに包んであげるよ
Wow. Hi, Gab. Morning, afternoon, and evening. Hi. I hope you guys are doing super well. Happy Wednesday. Congratulations on making it this far. Happy 21st of the month. And I can't believe February is almost over. And how is it midterms and But I hope you guys are having a super duper duper good Wednesday. We'll talk about all the nonsense happening today, but thank you for working with me today. We are starting to stream about 30 minutes earlier than scheduled. I was just getting really nervous. I was like, I don't know if I know anything about the exam. So I was very dedicated and getting a study stream in here. So thank you for coming in by. Thank you. Sorry to anyone who's like, oh, I can't wait to work with Tippa today. Yeah, sure, you can. I'll just be blabbing for the next 5 hours of my life, okay? Actually, I don't really know how long this is gonna take, so let's cross that it's within a reasonable amount of time, so 1, I can walk again, which that's the story for later. And 2, it will be before my exam at 7, so yay! Oh my goodness. But yeah, let me say my hellos before we get super into it. But hi, and say hi to Barun. Hello, welcome, Galmer. Welcome. Hi, Gallo as well. Hi. Welcome. Walking on in, brother. We're gonna get our 10,000 steps in together. Or sorry, together. You know, in honor of the Elden Ring DLC, which, by the way, I didn't actually get to check it out. I didn't see the trailer. I've only seen people on my Twitter feed drop, like, Elden Ring DLC! And SMT5 Vengeance, here are all the pretty pictures, and here's Jack Frost as the main character. That's really been on my feed today. I did get to look at the direct today, but it wasn't anything, like, super impressive. I'm sorry. I watched it with what do you call it? Lighthouse, who is streaming right now, and oh no, they're gonna hate me because I misspelled their name because it's only one T. Anyway, they were streaming and I was like, oh shoot, that's happening today. And they watched both the English and the Japanese one, and I feel like a weeb if I'm like, yeah, the Japanese one was better. It actually dropped Mother 3. And it has a guitar game. Where it teaches you guitar if you didn't really quite get the, the implication. So I'm like, man, we don't get that? Lame. But it truly is what it is. But anyway, sorry. I got distracted. Hi, Ruma. Hi. Let's go. I can't believe it. Welcome on in. Happy Wednesday. Hi, Seth. Happy Wednesday to you, too. Midterm stunning? I know. I just don't really understand how it's February. And it's like, oh, midterms? And I'm like, what? Technically, I guess my finals are in April, and in 2 more months it will be April. But I'm just really confused to where this like the semester is going. I feel like I haven't learned a lot but I feel like I have to learn a lot, or everything that I feel like I haven't learned, I have to cram between now and next week. Just for the occasional midterms. So we'll be doing lots of learning today. I'm so sorry it's so generalized. Again, I feel like next week will be better because again, it's like, oh, here's your heart and here's your spine, and everyone's more familiar than that. Now I feel like today I'm like, here are the different settings that we can practice as rehabilitation specialists. Here are some coding rules that we should follow. Hey, did you know you should treat patients with respect? Sorry, I apologize. But at least the knowledge is very digestible, but it's still a lot that I would feel very much more comfortable at least talking about. So, yay. Oh my goodness. Hi, Helby. Hi, Galmer. Welcome on in. Let me give you a whole fucking shout out, Gamer. Midterm time, you got this. I believe in you. Thank you, Gamer. Thank you. I appreciate it. I need all the luck I can get because, brother, I don't know what's happening today. I just know I'm taking a midterm and that's it. It probably really doesn't help that some of my classmates are like, hey, LMAO, did you know that some of the people in the cohort above us, all of them actually failed their finals and it had to be rounded because they couldn't fail the whole class? And I'm like, what? So I'm not looking forward to this midterm. I'm like, wait, the final is like that. How about the midterm? And the midterm, oh, sorry, the final is more important because blah, 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 blah. That's the test, blah, 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 blah. And that's going to be incorporated in the grading, whether I actually fail? What I'm talking about. Pass, not pass, fail. Pass or I'll fail the course. Yeah. So we'll see how it goes. I'll update you Cubs on a Friday about that. Or on Thursday if I end up gaming. Hi, Caleb. Hi, Galmer. Welcome on in. You're gonna beam my knowledge directly into my cortex? Brother, I need it. Well, thank you, Gamer. I really appreciate it. Welcome on in. I hope your studies are also treating you super well. Hi, Nona. Hi. Welcome. Brad, hi, welcome. And oh, my head pads. Whoa, I'm short for my head pads? Or maybe it's like perfectly the right size. I love a little scalp pat. Thank you into the head pad. Thank you. Banana, hi. Brad, thank you so very much for the 55 stream streak. Holy gal. 55 stream streak. Let's go. Maybe I need to touch some grass though? No, brother, maybe I need to touch the grass. We can touch the grass together. 55, that's crazy. But you already touched grass. You went on a run yesterday, and if you didn't touch grass yesterday, then that was on you. I'm sure you'll get plenty of opportunities because it's still pretty early today. Again, it's either you're an EU cub or you're an EST cub. No other time zones exist. I'm sorry. Sorry to anyone else. So I'm like, oh, it's early. That's fine. Oh my goodness. Nona says, where I'm from, we call exam week Heck Week. Yeah, I would too, brother. I have an exam on, let's see. I have an exam Tuesday and Thursday next week, so we're basically all gonna be studying, so bye-bye. Hi, Nydia, hi! Gamer, hold on, let me shout you out. Hold on. I shout you out in the way that I know how. Go follow Nydia! Ah! Nydia, I'm so sad. This is well, this is not directed towards you, but I've been on testing. Okay, well, actually, I shouldn't. Well, did I mention it before to you, Cubs? Gosh darn it. Either way, I was working on something and I accidentally deleted it, and I was so sad. I was doing it after anime night, and I guess I was so delusional after that ending of Zom 100 that I was like, oh, I'm gonna try to see if I could finish this up before it hits 11, and then I can lay in bed. And then I accidentally deleted the whole thing, and I wanted to cry. I was like, so I have to work on it again, and I'm so sad because normally I take screenshots and send to friends to be like, hey, does this look good? But I just kept sending them a link because and I was like, wait, will the Wayback Machine help me? And it doesn't, so I'm like, nah! So now I have to do that all from memory again. And I don't remember how I formatted it, but I remember I was just so happy when I was like, yeah, I can't wait to post this all and da-da-da-da-da. And it's like, no. And I'm like, no! Not even a Word document? Past typo, why? Anyway, I'm done complaining. But just want to let you know, 11 p.m. me was not happy. I was like, ah! Oh my goodness. Anyway. Gala says, I'm very glad I have a character that already beat the game so you could jump right into it. MK DLC? Gamer. Again, I have not watched anything trailer-wise with Elden Ring, but you know what? I did watch a video. You know that video where I'm like, I'm gonna defeat the fire giant in Elden Ring? Apparently you could have a summon. No one told me this. I was wondering, every boss battle I had a summon, and I'm not talking about the summon you have on person, but like an additional character. You can get the jar guy, Alexander Hamilton. You can get Alexander to be in there, but you have to do his quest, and I'm pretty sure I've done most of his quest line, so I'm kind of like, oh. Oh, where is he then? Maybe I haven't looked right. I'm so tempted today, sometime today, we have time. Or if I remember sometime this week, or maybe tomorrow, who knows. I want to log into Elden Ring. Log in like it's an MMO. I want to start up the game Elden Ring. And be like, wow, is he actually there? I don't know. And if he isn't, I think it's like a little bit of backtracking to go into a pool of lava to run into him. And I'm just like, oh, gosh darn it. I just want to get past the fire giant and for my controller to work. Oh my goodness. Hi, Seth. Hi. Good morning again. Hecky weeb, we're shoving you into a locker? Brother. Good thing in my high school we didn't have lockers for God knows whatever reason. Huh? A weeb? Disgusting? Go take a shower? Gamers, you're making my heart hurt. Kind of girl does not roll out of bed, decide to eat oatmeal, and then say, hey, I'll shower after my walk? Damn. I can't have anything in Bearcat Mountain, huh? Anyway, hi, welcome. Oh, my first chemistry class only mean another pass without shenanigans? Brother, every course I feel like I've taken after undergrad has been nothing but shenanigans. Oh, well, physics undergrad was a lot of shenanigans, but we don't talk about that. What do you mean the exam is open response? Brother, I barely know what I'm doing. Oh my goodness, but I'm glad that you're where you are now. Not taking any shenanigan classes, unless you are, then no. But I can't replicate that noise. Maroons! Oh my goodness. Thank you for the 100 bits. I appreciate you to itty bitty bits. Princess, I believe in you, Tip. Keep doing great work and beat these exams. I will, and you'll see me on the news. Bearcat beats exams. In jail. No, but I appreciate it. I'm not like panicking about today's exam, but I'm sure after today's stream I'll feel a ton better. But thank you for the well wishes. I really do appreciate it. Thank you. Oh my goodness. Karma says medical question. Oh brother. Oh, okay. Is it normal to have feelings of happiness and excitement when receiving the Discord going live notifications from Tipa? Completely normal. I felt really happy when I got the opportunity to catch a full Moko morning before stream. So I understand, and anytime I see Rip go live, I'm like, oh, poggers! I feel so bad. I'm in a lot of like Discords. Please don't call me out, okay? I'm actually in a lot of Discords, but there's only so many people I do end up catching live when they actually ping to go live. Let's see how many servers I have. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Oh, brother, did someone just go live? Anyway, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, here it go, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68. I went away. Nice. So, I love supporting people, but it's really hard for me to catch their live notifications. So right now, I'm one of those people who have like the big number. Thankfully, they updated Discord where if it's over 9 notifications, they won't give you like a bigger number than that. But I am way past 9 notifications. I probably missed a lot of people's lives. Go Minnesota. But not saying that anyone's more important or anything, but I try to catch anyone who's on like the top of my Discord list, like Yanika. Like I catch a lot of Big Ham streams and Rip streams when I can. Anyway, but thank you for keeping me in your flop thoughts. Thank you for keeping up with the Discord notifications as well. Thank you for being a better bearcat than I am when it comes to that. Thank you. Welcome, morning to you, Karma. Welcome. Oh my goodness. No, thank you so much for the curse head pats. Hold on, I'm gonna speed run this and I'll get you some curse head pats, okay? Okay. Rip time zones? Rip time zones. Jillian, hi! My face with no version history? Brother, the worst thing about it is that with the delete thing that I was talking to you Cups about where I was devastated last night, there's no like warning of like, okay, I was trying to change an image. And then I was trying to, I'm messing around with the looks and comparing and blah, 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 blah. But when you click remove, I thought it was to remove image. No, it removes the whole thing and it doesn't give you like a pop-up warning of like, are you sure? No, it just deleted the whole thing! So it's so sad, but it's fine. Anyway, Brent says, oh yeah, I forgot to say it yesterday, but no one typed anything while we were watching Zom 100. That was really funny. No, that Teru emote that I put, that was my face the entire time throughout that ending. Don't get me wrong, Zom 100 is a funny, haha, silly anime, but I was not a fan of the ending. And I know because you can't really wrap up the series like that, but I'm like, gosh darn it. How to say it? It's not that I don't want to spend my time watching funny haha animes, but I'm like, gosh darn it, there's only so much time. I want to watch, you know, at least animes that are rated 7.5 or higher in my book. I don't know what I would rate Psalm 100 though. I guess it would have to be lower. I guess it would be a solid 6. I didn't really think about it too much actually, about rating wise. I was just like, yep, glad that that's one anime out of the list. Throws it out the window. Man. But it kind of inspires me. I've never been one person, or bearcat, sorry. I've never been the bearcat to watch a lot of like zombie-esque movies or you know, genres surrounding that. But I wasn't kidding when I thought like School Life probably did it best in my more recent memory. If you haven't heard of School Life, let me see if I could get like the little recap. But it's like a cutesy anime. It's a cutesy anime, but these like group of girls who are stuck in school while there's like a zombie apocalypse around them, and they try to survive it. The anime came out in, let's see. When did the anime come out? 2015. So the anime came out a little while ago. But I was really hoping they were gonna hit us with a second season, and they never did. And I was gonna read the manga, but I never did. But I love me some psychological horror aspects, and that just had like a nice hint of it towards the end, so yay. And if I want to watch zombie anime, I feel like I want to like rewatch it or like put my time into reading that again, you know? But yeah. Hi Pilot Bill, hi, welcome Galmer, welcome, good morning, good luck with exams, thank you. Sorry, I was on a ramble and I was like, oh wait, let me catch up, hold on. Caleb says inside your uni there are 2 wolves. One is a long answer exam, the other is an oral exam. You're panicking? Brother, that's me with my spine class right now. I have like an oral quiz sometime, who knows, maybe next month, and I'm just gonna be there in front of my teacher. 3 minutes to answer. I'm like, tell me about the spine. Anything. You're back? And so we'll see how that goes. I will definitely be putting some more time into it so I feel more comfortable with it. Again, I just, like I mentioned earlier, I don't feel like I've been grasping anything this semester. Not because it's bad, but it's just been like a lot of information thrown at me and I haven't had the opportunity to sit because each week is just like, do these busy work assignments. And I'm like, oh, I just want to study. Is that bad? I sound like a nerd, but it was just like, I just want to study and understand the concepts. But now I have the opportunity because at least some of the exams have kind of narrowed down because my professors kind of have an understanding of like, oh, it's midterms, they should be studying. Hackers. Oh my goodness. Eh? Julian says I'm at my 100 server limit constantly, brother. I don't think I can do it. A lot of, again, my Discord servers are like a lot of mutuals and friends. I have a few that are like little groups and like personal servers, like my school server, but that's about it. I couldn't imagine. Whoa! Oh my goodness. Rebel says Tippa joins the Discord server for everyone she follows on Twitch. No, I don't. I'm just in a few, okay? Just a few. And I try to organize them into folders. So then I can right click like, oh, this folder has 117 notifications. I could just right click the folder, mark as read, bam, I'm responsible, baby. Oh my goodness. If Tippa's not on your Discord server, she hates you. No, I just literally don't remember sometimes. I felt embarrassed because, well, actually, we won't talk about that. Anyway. Oh my goodness. There wasn't much to say until the funny sickness reveal. Oh yeah, that was really... yeah, Zom 100, everyone. Anyway. Hi, welcome. Tippa will only watch based anime? I will! Have you guys heard about the indie anime of Madoka Magica? Yeah, anyway. Thank you for the 18. Say the bad word. I gotcha. Welcome on Inui. Hi. Caleb says you're starting watching Tokusatsu and you won't have time to worry about anime anymore. Woohoo. Wait, ho? Why'd I say hoo-hoo? What's ho-ho? Oh my goodness. Well, I hope you're enjoying it at least. Hi, Gemini. Enjoy your lunch break. Thank you so much for stopping by the way. Hi. Bye. Have a yummy lunch. Oh my goodness. I ate some oatmeal cups and I wasn't really filling, but I had ate like too much where I didn't eat all of it. So I'm like, oh, I must be full. And then I sat here and I'm like, she was not full. Well, I have some coffee at least, so it's fine. Huh? Wee says maybe the real message was the life only really starts when the world goes to heck. Brother, that was the plot of Zom 100. Wait, are you just talking about Zom 100? Because that's what we're talking about. Julian's like, brother! 2015 was yesterday, brother. That was yesterday. It dies. Imagine everything you've done up to now was just like a dream. You're actually back in 2015. Brothers, I cannot tell you where I was even... Where was I in 2015? Anyway. Tell me about osteoporosis now? No, thank you. Camp says just mentioned that the lumbar vertebrae doesn't have process transferalis and that their actual processes, is the mammillary process, and they'll love you for that. Brother, they're gonna love me for that anyway because they want me to talk about the multifidus muscle and what it does and where it attaches to, and knowing that it originates from the C4 to C7 all the way down the sacrum, and it actually attaches into the mammillary processes to help you do side bending, rotation, and I feel like I'm missing another action. Gosh darn it. I would love to pretend and say flexion, but I don't think it does flexion. And if it does, then oh. That just means I have to study. Hi, Asa. Hi. The right end is the coccyx, or however you spell it? No, you're so good, brother. Everything in anatomy? Stinky. Hi, Shira. Hi. Welcome on in. Welcome. Eh? Julian says, write a 500-word discussion post about the last 2 chapters. Gamers, did I tell you? Sorry, I'm losing it now. I feel like I'm going on like a downhill spiral of like remembering homework assignments, but I just did a discussion post where I had to record a video talking to a patient, and again, the whole idea was like, oh, let's see your mannerisms and blah 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 blah, and people will critique you. Well, I had to reply to 2 of my classmates and write 250 words. Brother, not 250 letters, 250 words. It was so annoying. Because I wrote like a short 3 to 4 paragraph sentence. I'm like, whatever. And then my classmate messaged me. She's like, Tip, I don't think you read this right. It says you have to write more than 250 words, not less. And I'm like, oh, math. So I'm getting like war flashbacks to last week, but it's okay. What is the medical equivalent of technobabble? Technobabble? Like, you mean like jargon? Or wait, maybe you mean something else. I'm sorry, gamer. My mind's not here. Oh my goodness. Anyway, I'm so sorry, Luna. Luna, I owe you head pats. I'm so sorry. Here, I got you. You ready? And a 1 and a 2 and a skibbity doobity doo. I know, aren't my hands so cool? They're so detachable. Anyway, but yeah, let's get into it. Gamer, small emoji. Hopefully, I didn't miss anything else, and if I did, well, ain't that life? I try to read everything, but sometimes streamer brain literally says, haha, what? And I'm like, what? Anyway, let me sip some water and then we'll talk about what we're getting ourselves into for the next 5-6 hours. I don't know. All right. So today the topic is what did I write in the title? Patient care and patient billing. Yay! So again, these things are kind of all over the place. Even the midterm review is a little bit all over the place, but as long as we get to talk about the concepts, I feel like, again, I would feel better about whatever I'm going to be quizzed with later. If we have enough time and I'm really crossing paws and toes and fingers and everything else I can cross, I'll start braiding my hair. I'll cross the hairs there too. That we'll have the opportunity to go over the Quizlet. And now, don't get me wrong. If I get through this guide and it's cutting it a little bit close to exam time, which is at 7 p.m. and right now it's 12 p.m. EST, I might just do the quiz that's off stream because it's much easier for me to go through the flashcards than to be like, what is blank blank blank? Oh, Cubs, do you remember what we talked about 5 hours ago? Wow. Remember this concept? Wow. The answer should be wow. And then I have to do that for like 187 terms. And then I found like a second Quizlet, so it kind of depends on how we'll go and see. But that's really why I wanted to start the stream early. Technically, I wanted it to start earlier, but I got distracted by Fuamoko. Fuamoko morning! Oh, it's Wednesday, my cubs. I had to watch it. Anyway, yeah. Bye-bye! Monte, hi! Welcome, Gamer! Welcome! And yeah, 5 to 6 hours might be an exaggeration, but you know, a lot of it's talking. Like, look, Cubs, I already spoke for like about 27 minutes. Non-stop. No inhalation of air in there. Brothers. Hey? Your bill is 10K, patient? But I just showed up? Yeah, that's all you have to do. You show up, your knee hurts. It hurts when you put your leg out, you extend your leg. Yeah, maybe stop doing it. All right, here you go, 10,000. Anyway, so the midterm, I'm not gonna lie to you, is kind of all over the place. But we'll break it down into certain sections. There's some sections that I would love to work with you Cubs with, just so we have a better understanding, and by we, I mean me. I was saying yesterday that I was organizing the notes, so this formation may also be all over the place. Some of the formation is some of my own personal notes. Some of these are just straight up screenshots from the lectures, and some of these are just notes from my other classmates. So let's get to it, okay? So, we're gonna break down patient care in a sense of there's a billion, well, not a billion, there's a 1, 2, 3, 4, 5, 6, 7. There's 7 different rehab settings that we could discuss when a patient needs some kind of orthopedic care. And this can vary from they need as much help as they can, maximum, to very minimal. So this was actually like a little activity in the lecture that just is like mix and match what setting. So we'll go down the list and talk about the different settings. So if you ever need help, you can go into a assisted living facility. Let me see, does my mouse capture? Yeah, cool. Sorry, the words also cut off, so apologies. But yeah, so your patient's unable to live independently. Maybe they're not able to move around. Maybe they're not able to do their tasks. But basically, just think of a much older person, maybe almost bedbound. But they need help getting up, they need help toileting, they need help with a lot of things. So they are not able to live independently, and they don't really have a caretaker or a family member to, well, take care of them. So this is why they live in these assisted living facilities. But actually, maybe in this case, they're a little bit more forgetful because the only assistance that they need are with meals and medication. So yippee! Hi, Omni. Hi. Welcome on in. Welcome. Yippee is right. So yeah, we have rehabilitation centers where maybe your patient had a stroke. And if you cubs are unfamiliar, strokes normally. Pretty much you have like a one-sided weakness, whether it's like your left or your right side, depending on where the stroke is. And you lose strength in both the upper and lower extremities, so you're not able to use half of your body's arm or leg. So with rehabilitation centers, let's say again your patient has a stroke, they're going to need treatment to restore that function, because again, this is going back to the concepts we talked about when we were taking neuroscience or neuromuscular, and it's the idea of the 10, I hope it's 10 principles of neuroplasticity, and it's the idea that you use it or lose it. And it's kind of like, yeah, well, the stroke, I kind of lost like half my body's function. And it's like, but you can regain that, but you have to practice. There's the other principles of like intensity matters, force use, in a sense that, yeah, I know you're very functional on the right side, but your left one is the one that got affected from the stroke. Hey, maybe we should encourage you to use your left side more. And this is like a huge throwback, but this was technically last semester or a few months ago. If you cubs remember the is it called CIMT? Constrained Induced Movement Therapy, where basically you would put a patient in an oven mitt on their functional hand, and that would quote unquote force them to use their opposite extremity to do things such as reaching or grabbing, etc., etc. As this is blood clot to the artery in the brain, if I remember right. Yeah. So there's different kind of strokes. The most common one, I think, let me not say words if I'm not sure, is ischemic stroke. So basically you lose like blood to that area, and yeah. And it's ischemic because there's a blockage, or hence the blood clot, and yeah, stroke. Ta-da. Yeah. A stroke sounds like a factory reset. Well, strokes can mean various things depending on the context. Like, when people say, haha, you got a stroke of luck there. And it's like, what? If you think about stroke in only medical terms, it's kind of like, don't put that word next to me or near me. Stroke of what? But yeah. But yeah, oh, sorry. So yeah, patient has a stroke, they'll need treatment to restore and learn how to compensate for their newly acquired physical disability. You determine that this patient will be able to tolerate 3 hours of therapy a day. And isn't that crazy? Imagine going to therapy 3 hours a day, but again, it's the idea of like, how fast can we get you to be as functional as you could be? And again, there's like really fun before and after YouTube videos that you can look up with people with strokes, but thankfully it's not the end of the world if someone has a stroke. That's really good, especially for how common they are. Caleb says, yeah, ischemic is the most likely cause, and among those are ranking as the embolic event, thrombotic event, vasospasm, and then minor causes. Yeah. I don't think I don't think this course goes through it, unfortunately, as in depth with the other courses. But yeah. If you're ever curious, Cups, just be like, Google stroke. Hi, Ricky. Hi. Welcome. I'm so sorry, Ricky. I promised you, I game. I'm just in midterm heck right now, which, you know what? I didn't even write that. Midterm heck part 2. Bam. Now it's in there. It's in the title. It's official. Well, 2-hour workout makes 3-hour therapy seem normal? Honestly? Yeah. But some people are unable to tolerate 3 hours, and I hope this guy talks about it, but I don't think it will. Well, if you're half paralyzed, what else are you going to be doing? I mean, you're right, but some people... It's hard. It's really hard. I mean, everyone goes... How do you call it? Copes in different ways, and I'm sure there would be a lot of people who may have a stroke and be like, yeah, it's the end of the world, and it's just like, oh. And then they don't do anything, and they stay in that condition, you know what I mean? But therapy is super duper important for situations like that, because you want to get them back to, like, at least a functional level, you know? Luna says a V2, oh, the autocorrect in my brain. A YouTuber I watched got one of those and he made a good recovery. Oh, I'm so glad. That makes me actually really happy to hear. Again, there's really good prognosis for a lot of people with stroke, thankfully, but it is a huge life-changing event. You're gonna draw trivia? You're totally fine. And Ricky, it's cool, thank goodness. And Monte, Keck, me too, internally. Some YouTubers are meat YouTubers? What? Do I have glasses with the prom outfit? I don't think so, but I can switch. You'll just have to give me like 5 minutes, or I could just put PNG glasses on me. I got the technology now. but just let me know, gamer. But yeah, let's get through these a little bit faster, because this is not the main thing of this at all. But this is the idea of like getting you familiar with the different kind of settings, you know. So acute care facility. So pretty much what happens is acute care. This can refer to hospitals and whatnot. And this is a setting to discharge the patient as soon as they're medically stable and that they have a safe place to go. I can't think of an example right now because the last time I worked in a hospital or did shadowing was a very long time ago. Sorry. Maybe after surgery, post-surgery. Anyway, there's rehab hospitals. So this is a specialized facility that's going to treat patients with extensive neuromuscular or musculoskeletal involvement, usually 3 hours a day to restore function and or lose my voice. Hold on one moment as I die. Oh my goodness gracious. Wait, I should sip water. Hold on. The education stream need glasses? Yeah, they do. I need it because I can't read. I can't read without them. Sorry, gamers. Alright. Also, gamers, is the music okay? Is it too quiet? Too low? Please also let me know. I just finally stared at my mixer and I'm like, oh. Might be a little low. Whatever. It's fine. My voice is the music! Anyway. Music is a bit low? Okay, hold on. I got you, gamer. Sure. And hopefully that's not too loud. Okay, and if it is, then I'll put it down. I'm sorry. Good for background. Let's go! Alright, gamer, thank you so much. I appreciate it. Alright, Brother, there's so many. Alright. Let's talk about outpatient orthopedic, which is right here. And so this is going to be a setting where individuals with short-term musculoskeletal issues are treated several times per week for several weeks. So a good example of this is maybe you heard a lot of people who may have torn their rotator cuff. So these are people who have maybe some kind of shoulder injury. They go to rehab and they usually go for, I think, anywhere between 4 to 8 weeks. And it's normally about 2 to 3 sessions per week. Industrial facility is something really interesting because you don't really hear a lot about that, but their goal is to treat and help patients return to work to improve employee health and safety. That's a whole bucket of worms, basically. A few courses ago, we had to do like a fake scenario about a firefighter who had hurt something. Oh my gosh, it's been like a year. I'm so sorry. He had hurt something, but we needed to basically get him approved for work, and we had to do these like work specific tests to make sure that like, oh yeah, he's able to do it because he was able to do XYZ examination and he's safe to go back to work, you know? Skilled nursing facility, I feel like that's also a common location that I feel like a lot of you cuz may have heard. It's also abbreviated as a SNF or an SNF, skilled nursing facility. Their goal of treatment in the setting is to restore patients' ability to function independently enough to care for themselves or to a level where others at home can care for them. Typical stay is anywhere from a couple of weeks to a couple of months. There's also subacute rehabilitation, and so this is the difference because we talked about a setting, rehabilitation setting, and rehabilitation hospital right here, where they could the patient could tolerate about 3 hours. But how do you call it? Subacute, because it's not as recent, it's subacute, it's been a little bit longer in this situation. The therapy sessions don't last for the whole 3 hours. They're actually a little bit less intense. Sniffa? Yeah, I guess. During treatment, he was able to carry out an old lady out of the house that we set on fire. He's good. Yeah, he went through our simulations and did great. He was able to carry up to 120 pounds in weight to save that little old lady. Oh my goodness. Alright, and then we have long-term acute. So a long-term acute facility, serious medical condition, intensive special treatment for extended period of time, usually 20 or 30 days. Okay, let's get out of here because that's not our focus for this class. It's just saying like, oh, look at all the wacky settings. Haha, ho ho, wow. Alright. So now that we're done talking about settings, we could talk about the level of care people will typically get. And this doesn't have to be in a rehab setting specifically. This is just the healthcare field in general. So they divide these type of cares by primary, secondary, tertiary, and also don't ask me how to what quaternary. You know what, that's great. Let's Google this really quick. How to say this?
Quaternary.
Quaternary. Oh wow. Wow. She made the same ba noise she does for her curse head parody. Sorry. It's almost the equivalent of blah 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 blah. For stage, yeah, quad meaning 4, but I'm just like
Quaternary.
Quaternary. But yeah, so for primary care, what happens is that this is when you normally go to your primary care physician, maybe your family doctor, maybe someone you've been seeing like, I don't know, for years. Do I have a PCP? No. But this is typically someone that you would see whether you have like an illness, an injury, or maybe you got referred over. This is just someone you consult to be like, hey doctor, I've been having this flu for 3 weeks now and none of the over-the-counter medication is helping. What do I do? Kind of situations. And oh my goodness, I hope you don't have that for 3 weeks. That's crazy. It can evolve, and sometimes it could become secondary care. So this is when you start to see a specialist, because PCP, your primary care physician, is very generalized. But maybe you have something more specific that it's like, yeah, you need a referral, you need the specialist to see you. And I'm sure you guys have heard about like cardiologists, which are going to be specialists for the heart, endocrinologists, which is like your hormones, people who have like RA, etc., or oncologists, which are people who specialize in cancers. Yes. From there, maybe you even you need even more specialized treatment from that. And this is something that only hospitals typically offer. It's something that requires like highly specialized equipment. So this is going to be, maybe you need a cabbage done or a CABG. A CABG is a coronary artery bypass graft, and this is please forgive me, I'm in cardio and I don't know the full facts because I haven't studied cardio. But to get a cabbage or a coronary artery bypass graft, this is when I believe you have a blockage, and they're like, yeah, don't worry about that, chief, we got you. And it's like, oh, okay, great. Let me actually get actual information for you. What? And whilst taking a blood vessel from another part of the body, usually the chest, leg, or arm, and attaching it to the coronary artery above or below the narrowed area of blockage. This new blood vessel is known as the graft. So yay, you get a new artery, yay! It's similar to when people get the surgeries, like the plastic surgeries of like... What is it? Don't people get like a Brazilian butt lift or something? They're like, yeah, we actually took like the fat from your legs and we put it to your butt. It's basically that, but this is more like, you know, more vital to life because you have a blockage. And it's like, oh, we just took this artery from another part of your body and here it is. Ta-da! Are these my personal notes? Yes. I love making notes pretty, but this is kind of a combination of, how do you say it? My notes, my classmate notes, and some stuff that are just straight from lectures. So you're gonna see a lot of inconsistencies. So gomena sorry, gomena sorry. Oh my goodness. Caleb says your coronary artery is blocked, so you just put a little workaround in that bad boy? Yeah, basically. Ta-da! Yeah, still the artery and you put it over the heart. Luna says Elden Ring taught you about... Elden Ring taught you a lot about grafting. I'm glad. That makes me very happy. You thought this was from a textbook? No, this is my this is from Google Docs. This is me typing blah 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 blah. Oh my goodness. But yeah, so that's tertiary care. So you'd have, again, very specialized care. So we have the cabbage, we have a dialysis, plastic surgery, anything relating with neuro, with the brain, and burns, because yeah, oh my gosh. Well, maybe I shouldn't share this information, but I know someone recently had gone through a burn situation and they needed to go through all sorts of treatments. And I'm not telling you to Google this, Cubs, but there is different degrees of burns, and you know, the more severe a burn is, yeah, the more, you know, more likely you need to get care from the hospital. Yeah, and how did we say we were gonna say this word again? Quaternary care? Yeah. So this is going to be advanced level specialized care. So it's really specific, and to the point that this is going to be experimental or just really uncommon specialized surgeries. Like you hear a lot of people are like, oh, my knee, or oh, this or that. But maybe it's something a little bit more unique that requires this kind of care. So those are your 4 different categories of care. A lot of you, hopefully, are only probably going to end up in primary care and secondary care for most of your needs, you know? Unless something actually happens, which I hope it doesn't. So yeah, that's Unit 1, quotation mark. Now we're gonna move on to how to talk to patients 101. Huh? 4th degree burns are some kind of light? No! Yeah, 4th degree burns are not pretty. I did hear about the fish skin grafts, which seem really nice, you know? But yeah, Ricky, no, please be careful. I'm not really fond of gore or anything like that. But some of these burns are... Anyway. But yeah, when we're talking to patients, we can use 2 different kind of models, right? These models are what we consider patient-centered care models. And we have the AIDIT, or IDIT, and RESPECT. They both do basically the same thing, but there's different ways of how to go about it. So for the let's say IDIT model, this is going to help with communication and demonstrate empathy. Not apathy, empathy. So it's like, wow, my patients have feelings? Amazing. dyes in my voice. This is gonna help improve clinical outcomes, and it's gonna help reduce burnout caused by communication. And this IDET model is actually a mnemonic. So as you see here, the A stands for acknowledge, I is for introduce, D is for duration, E is for explanation, and T is for thank you. And then it's broken down further into this little graph right here. So for the IDET model, again, A is for acknowledgement, where you greet the patient by name. Oh, hi, Mr. John Smith. Oh my goodness. Do you prefer John or do you prefer Smith? Oh, Smith, okay. Mr. Smith, nice to meet you. My name is Tipanya. Yes, Tip as first name, A as middle name, Nya as last name. Nice to meet you. I'm a student. And I stare at them, and I'm very good at staring. You cubs have seen me in the pomodoros. I'm going to make eye contact to know that I am acknowledging them. I'm going to smile too. And I will also acknowledge family or friends in the room. Eh? Caleb says wait, IDK about grafting? Eh, but I heard about it being used for bandages for severe burns? Oh, wait. So it's like more of a temporary? I thought there was more of a permanent solution with the fish skin, but again, I haven't really looked into it. Maybe if I specialize in wound care, which I won't, I'll come back to you and get back to you and be like, oh yeah, guess what? But maybe they also do it differently in Bearcat Mountain, so I don't know. Asa says apathy. Patient, I'm in a lot of pain. Oh, I don't care. Nice to meet you. I'm a bearcat. I go gal gal and nya nya, and I make all the troubles go away. And it's like I'm in such severe pain. My pain is in a 9 out of 10. Would you like to go gal gal nya nya and maybe make it an 8 out of 10? I don't know. It's really nice to have someone in like high spirits. I would never do that to the patient though. That's unprofessional. But yeah, so acknowledgement's very important. It sounds really dumb, and it is, but I guess some people just go in there and they stare at their like laptop and they're like, name, date of birth, what are you here for? Okay, good, bye. You know? The I is to introduce yourself, so basically be like, hi, my name is so-and-so and I do so-and-so. The D is for duration, so you want to make sure that your patient is heard. You don't want to be like, yeah, I'm here for my rotator cuff, and you don't hear maybe how that happened, how that's impacting their lives. You know, people really just want to be heard when they're in situations that make them so vulnerable. So for the duration, again, you want to give patient an accurate time frame of the duration of their visit, including information such as when they could expect to see the physician and lab results. And when this is not possible, let the patient know what time you'll check in to update them with their progress. Sorry. E is for explanation. Explain each step of the visit, answer questions, and let them know how to contact you, such as drew a call button. And T is to thank them. Thank the patient, express gratitude for choosing your facility and their communication and cooperation. Thank family members and friends for being there to support the patient. Yeah. Great job. Oh my goodness. Julian says, I feel like Tippa's bedside manner would be good. She would remove a band-aid the correct way. Oh, Cubs said, did I tell you the... I did, but I'm gonna rephrase the story for the Cubs who weren't here after I cough up my lung, okay? Give me one moment. I don't know why. This right now. I know yesterday I was like, oh, I might be getting sick. Thanks, Ryan. And now I'm like, I can't speak for the 5 to 6 hours I want to speak. But anyway, yeah, so I had an IV in me because I had a hospital visit because of the swelling stuff back in December. And when I wanted to get discharged because, gosh darn it, I was there overnight and I was not in a hospital room. I was like in their little, like, I don't know how to explain it. I was not in a hospital room. I was in like a little area that I was getting kicked in and out of because they're like, oh, you're not being directly cared for at the moment, get out and go back to the waiting room. And I'm like, what? I had to drag my IV with me into the waiting room. Oh, looking back on it, that was an awful experience. It was awful during the time, there's no doubt about it, but it's the idea of like, oh my gosh, I'm glad I wasn't actually dying. But anyway, not the point. Point is that when I wanted to get discharged, none of the nurses were available, so a PA or physician assistant came by to remove the IV, and he ripped the band-aid the wrong way. So it hurt like a hecker, and then blood started gushing out and spilled on my pants, and he's like, at least it's your blood, right? Like, you're used to getting blood out, right? And I'm like, kills him in Minecraft. if my stare could kill. Yeah, trust in your nurses, okay? That's all I got. Tip has a cough? No. I don't have a cough. I just, sometimes I sound like this, and I feel like the only way it could get better is that if I just, like, cough up whatever I have to, you know? Huh? I, too, simply just rip out patients' IV and tell them to get bent? Brother, the IV, if the technology was not there, the IV would have been stuck in me. Thank goodness for flexible needles, because that guy would have killed me. Anyway, respect! Yay! Respect! So respect is another mnemonic and also a word that we use in general, so it's a little 2-for-1. And for respect, what happens is that this is to promote physicians, I can't even say that right, I feel like I'm saying fish. Physicians' awareness of their own cultural biases and to develop rapport with patients from different cultural backgrounds. So, what do you call it? So R is for rapport, E is for empathy, S is for support, P is for partnership, E is for explanation, C is for cultural competency, and T is for trust. And then we'll go more in depth with this, okay? Hold up, you saw the needle in the IV? Yeah, that's why I started gushing everywhere. Oh my goodness, but it was awful. I don't know if I ever took a picture, not that I would show you that, but I had it for a really long time, and again, I wasn't in a room, and I ended up falling asleep in a weird way. I don't know, do I have MS Paint? Yeah, I ended up falling asleep in a weird way in the hospital room where I think I just had like my arm. I just like left my arm out hanging as I tried to like go to sleep on my other arm. But I guess I must have moved in my sleep or something because oh my goodness, sharing a picture wouldn't violate TOS? Yeah, I wouldn't share it, weak hubs. No, you know what's the worst part? It wasn't in Bearcat Mountain. My mama Bearcat and her finessing the system. I wasn't in Bearcat Mountain. Not that the medical care is better in Bearcat Mountain. Oh my goodness. But I won't share anymore because I'll just stay silent about that. Oh my goodness. But no, it was a flexible needle. Yeah, anyway. So R for respect is for rapport. And this is just a really fancy way to be like, hey, this is really important because this is to establish close and harmonious relationships with people. And how we're going to be able to do this is that we're going to understand their feelings and ideas and just have, you know, proper communication with one another, and to understand that the patient is not just a patient, that they're a person. Maybe they're someone's wife, husband, sister, brother, loved one, etc. And that they're more than just a rotator cuff injury, that they are, I don't know, a father of 500 or something. It's like, oh my goodness, you have so much on your plate. Oh. Anyway, the PowerPoint goes over about engaging with the patient on a social level, seek out the patient's point of view, because sometimes it's really important to know, hey, where do you think you stand here and what is like your concept of what's going on? So you can kind of fill in those gaps. Suspend judgment. There are some patients who will say some very quirky things and you'll just have to smile and nod at them and don't judge them out loud. And then just avoid making assumptions and recognize when you have what. When you have what? I don't know. Sorry, gamers. The PowerPoint did not finish, obviously. Yeah, I'm sorry. I don't know why that didn't... Yeah. Sorry, Orphish. Thank you. Thank you, thank you, thank you. I don't know why I didn't catch. Heck. Thank you, gamer. The patient could be someone's oishi. Treat them with care. Exactly. Exactly. Ah, good morning, Mr. Anterior Cruciate Ligament Rupture. I bet you were playing soccer. Sorry, I didn't mean to make that assumption. That's just a really common way. Anyway, E and respect is for empathy, not apathy. Empathy! And this is to understand their feelings. Oh my goodness. Remember that the patients come to you for help. Yes, you, specifically you. But I'm not even licensed. Nope, they came to you. And you should seek out and understand the patient's rationale for his or her behaviors or illness. And you should verbally acknowledge and legitimize the patient's feelings. Wow, you hurt? Yeah, I bet. I'm sorry. I will be a great whatever I'll become. But it's just one of those things where it's just really funny just to have it like straightforward of like, do this. And it's like, yeah, of course. I'm not gonna ever dismiss someone's feelings of how they're feeling. It kind of goes back to what my professor was explaining with pain scale. So yes, when you use pain scale when someone's hurting, it's like, hey, okay, we'll put it on a pain scale, 0 being no pain whatsoever, 10 being like, hey, we're gonna stop this evaluation, take you to the ER. Where are you right now? And a lot of people may still say that they're a 10. And even though they're sitting there with no other signs and symptoms, they're not crying, they don't look like they're wincing in pain or anything, they say 10 out of 10, you can't dismiss that, you know? You kind of just have to take it as is, and it's like, okay, well, our goal is to try to see if we can decrease your pain scale, or let's see if there's anything that triggers it or anything that helps relieves it, and we'll try to implement that in that session, you know? So, yay, empathy, yes. If you take good care of an oishi, you might get reincarnated as their child? Brother, the lore of Oishinako? Which, by the way, I know a few cubs may have dropped it or may have not got up to it, but I'm reading the manga right now and I'm shook. I'm shook. Caleb says empathy. If your patient is sad, then start ugly crying, like snot and tears everywhere. No, you can't cry. You can't cry because crying is unprofessional. Not only is that mentioned, I think, somewhere in this lecture, when I cried to my professor about a situation that occurred, he wouldn't talk to me because I was crying. I was like, ah! Sir, I don't mean to be crying in front of you. Literally, I'm talking to you as normal, but the tears are not stopping and I don't know how to stop them. And he's like, yeah, we'll just have to reschedule this meeting. And I'm like, ah! I don't want to talk to you again. I don't want to reschedule it. But we end up rescheduling it and it just sucks. I had to like pinch myself to stop crying. I'm just like, gosh darn it. Oh my goodness. Asa says I'm too sarcastic. So someone would come in with a cut on their arm and say like, so headache? Yeah, but sometimes maybe patients can appreciate that humor, but it really depends on who the person is, you know what I mean? But that can also be seen as like very unprofessional, you know? Rebel says, what is this empathy you speak of? No! You're just gonna understand the patient's feeling. Caleb says, 10 just means worst pain so far. Once you get the IV drip, it actually starts to bump down. Okay, gamer. I don't know. Some people are just like happy to get whatever, you know? It could be like nothing. It could be like a placebo, and they're like, oh, I'm just feeling so much better. And it's like, wow, amazing. What do you recommend for pain? How about a hammer to your thumb? Brother. There's no reflex testing for that. What the heck? No hammers. No, thank you. Yes, hello, Gamer! Welcome on in! Welcome! Midterm hype? Let's go! Let's go! Yes, I am midterming as we speak, and I'm learning about the power of talking to patients. Respect. Hi, but I hope you're doing super well, Gamer. Welcome! Oh my goodness. Perhaps let's politely run through all of this and then we'll take a little baby break, okay? Because we're already a little bit over the hour mark, so we'll speed it up, quotation marks. Also, we're on page 4 out of 42, so I guess maybe we should speed it up just a little bit. Anyway, empathy! So, okay, that's our R. Our E is our report. Our E is for empathy. So what is our S? Our S is for support. And so it's really being there emotionally, physically, and just having that social support and understand some of the barriers that some people may have and just offer them help. The PowerPoint talks about understanding the barriers, help them overcome the barriers, involve family members if it's appropriate. If you feel like the family members, they don't have a good relationship, then maybe you shouldn't include them in the treatment. But if you feel like they would add or help, then, you know, maybe getting them involved to help maintain this level of care would be pretty ideal. And really just understand that your patient must feel isolated in the situation because they're like, well, I'm the only one who has this condition. It's the idea that if you provide them support, reassuring that you're going to be there and available to help, that will warm their heart and they'll feel a little bit better, even if it's just a tiny little winny bit. Right? So for P, our P is going to be partnership. So what happens is that we should be flexible with regard to issues of control. We should negotiate roles when necessary and stress that we'll be all working together to address medical problems. And this could be from all parties involved, whether that's the other medical professionals taking care of the care, or it could be family members who are going to be moving forward with this, helping you with the care outside of our session or even within our session, because obviously you only have like a limited time with your patient depending on what setting you're in. Well, most of the time, most of the settings you only so long with them, so it's ideal again to help maintain the gains as mentioned previously. And then E is for explanation. So basically just check often for understanding and use verbal clarification techniques when we're talking to a patient, and maybe you explain the technique to them, you show it, you do it together, and it's like, okay, we need to make sure that you kind of keep this up and do it at home. Can you run back what we did? And they kind of refer to this informally as a teach back method. But really you want to explain that, hey, this is more than just your condition. This is your condition. These are the goals that you have of maybe getting out of the hospital. Let's assume this is like some kind of acute inpatient setting. And then what is the plan of care going forward? Are we going to put you in some kind of other facility? Are you going to maintain this in an outpatient setting? Or maybe you're going to get yourself involved in home health? It all kind of is up in the air because every patient is so different. All right, we're almost done with respect. D, cultural competency. So basically respect cultures and beliefs, brother. Basically not everyone has the same kind of growing up or background as you. I know, shocker. But it's the idea that you should be really respectful for that. Be aware of your own biases. Know your limitations. How do you call it? It's something a little bit less harmful, I think, when I ran into as a tech for cultural competency, is that someone, they were not able to be taken care by a, what do you call it, a male medical professional. They had preferred females, and that was just within their culture and whatnot. And so when I had to help them put a TENS unit on for, I think, like low back pain, they're like, yeah, I can't have a male tech or a male therapist do this. Can you do it? And I'm like, yeah, let's put you in a private room in the back so no one else sees you. And we'll just do this right here, right now. And then I'll put you with a little timer. I'll put you with a little bell, and I will come back in the allotted time. Have a good one. It's just like little differences in understanding that. There's no way you'd be like, oh, you want a girl therapist? Too bad. You know what I mean? Can't necessarily do that. I mean, but it's like, what if there's limitations? It's like, work around that somehow. I have no idea what to tell you in that situation. I'm sure you have some kind of diversity in your field, that you have both male and female workers in there. I'm sure someone can help. But yeah. And then the last thing for trust, or sorry, respect, is trust. And so it's basically, what does the PowerPoint say? Sorry. Self-disclosure may be an issue for some patients who are not accustomed to Western medical approaches. Take the necessary time and consciously work to establish trust, because the more trust that you establish, what's going to happen is that the patient will be more open to tell you what's going on. And that might be pretty vital, depending on how you're treating them. I cannot, unfortunately, come up with some examples, but sometimes even kind of venting about it or letting them vent about it can also improve their condition in that way, because they're like, oh gosh, this is bothering me, and you're like the only one who could probably understand it. Here, let me tell you. And it's that, again, establishment of trust that's going to really help build that. There are causes of trust issues. I'm sure we've all run to it. Getting too personal now. No, I'm just kidding. But in healthcare, there could be causes of trust issues because patients are very just hyper focused about pain. Maybe they had a negative past experience with like another medical provider. They're feeling vulnerable and need help and understanding if maybe there's just like this one misstep, and then they're like, oh, I can never trust you again. They really just want to put this problem behind them, and then they're really just hoping that we're able to listen to them to help alleviate their problems. And that's why it's really important to allow them that time to kind of just talk about their condition, how they're feeling, and really getting to know them more, again, more than their condition, and helping them get better and getting to their goals. So yay, respect. Sorry. Anyway, so let's go over the AIDIT model, respect model. So the AIDIT model, again, is the A for acknowledgement, I for introduction, D for the duration, E for the explanation, and T for the thank you. For respect, we talked about rapport, we talked about empathy, we talked about support, we talked about partnership, we talked about explanation, cultural competency, and we talked about trust. So these are the two models that we can use when we're talking about patient care or patient-centered care, where it's like, oh, you are in the middle of this, I'm just a part for the ride. Hi, Dip. Hi. Welcome in, Gallery. Welcome. I know, dragging out all the information from a patient, amazing. You mean I could demand that my building is built from an all-female construction crew? Brother, the world is your oyster. Sure, if you can find it. But I don't know. It might be a little tough, not because of the not because of anything, but I'm sure someone would be like, no, you gotta have at least one guy in there. The diversity for genders. Oh my goodness. What part is head pats and which one is ear scratch or scritches? Well, your head is your head, and your ears are your ears. You're welcome. I want my building to be built by an all-hamster construction crew. Now we're talking. Oh, brother. Let's get Big Ham involved. Big Ham could be our mascot. My religion demands that my daughter has to be a total babe. Sorry. Brother, you know how, like, subjective that is? Oh, my goodness. Like, have you seen those TikToks? Where it's just like, the person will take a picture of this person and it'll be like, what would you rate yourself? And it's like, oh, I think I'm like an 8 out of 10. You think others would agree? Oh, I hope so. And they'll like show a picture and it's like, what do you think this person is? Oh, wow, they're so hot. Yeah, I would say like a 9 out of 10. Oh my goodness, it's so silly. Big Ham Builders? I can't believe Big Ham has another opportunity career waiting for her as we speak. We can get this going. We can get the ball rolling. It's gonna be great. Oh my goodness. I don't think you should be giving head pats or ear scratches to your patient, but that might just be me. Maybe I'm not familiar with the... Maybe I'm not familiar. I wouldn't. Anyway. Yeah, so let's wrap it up. So we talked about the AIDIT model and we talked about the respect model. So let's talk about Picker's 8 principles of patient-centered care. So this kind of goes hand in hand with the AIDIT and respect model, but this is just more like, hey, these are the the basis of how we should be treating our patient in addition to these 2 other models. So basically, we should respect the patient's preference. We should have coordination of care, and if we have to integrate other health professionals to get them to their goal, then so be it. I feel like we talked about this recently about a patient having like depression, but maybe they're there for like their knee, and it's the idea of like, hey, maybe I think you might benefit from seeing a psychologist for some of the stuff that you've been handling with. I think some professional help will go a long way, and so you refer them over to that as well. And again, treating them as like treating them holistically in that way, and integrating other people will help improve their clinical outcomes, or well, something like that. Providing information and education is really important. Again, the patient understanding why they're there, what they're there for, and how to improve. Very good. Physical comfort. Yes. Emotional support. Yeah. Sure. Involvement of family and friends. Continuity in transition and access to care. So all these we're going to talk about a little bit more in order with the a little short explanation, and then we'll get to unit 3 and we'll move on to like theories of care. So woo. Oh my goodness. Sending the doctor baby right away? Oh no. Bearcat, can you build a 3D model in house? Bearcat can. Bearcat is specialized in 3D. Bearcat is very talented, you know? Petting a cat therapeutic, then petting a bearcat should also be? Yeah, but I'm a medical professional or soon to be. It's like petting your doctor, like, oh doctor, you're doing such a good job. Unless that doctor has a praise thing. I don't think that's appropriate. Anyway, let me sip some coffee and let's get into this really quick. Hold on. Coffee's so good. It's a little cold now, but it's okay. That just allows me to chug through it. Hi, Davey. Hi. Welcome, welcome. Hey there, Tippa. How's it going? It's going well. I just that's how I'm feeling, but it's fine. I won't go any further. Are these your own personal notes, or these are provided by the school? This is a mix of my notes, my classmates' notes, and some straight up, PowerPoint stuff. So please forgive me for the inconsistencies. Normally, when I go over streams like this, normally I reformat it for all of it to be basically my notes, but gamer, I did not have the time or motivation. Forgive me. That's okay. Anyway, 8 principles. Number 1, respect for patients' values, preferences, and expressed needs. So pretty much treat your patients with dignity, respect, and, you know, have sensitivity to his or her cultural values and autonomy. Basically, the autonomy of their own choice. If you're kind of like, hey, you have these options to choose for treatment that I believe are going to be helpful. Here are the pros and cons. You get the opportunity to choose what you feel like will work best for you. What is your own preference, you know? A shared document with friends? Oh, I wish. So sometimes we work on a study guide together, like what you probably will see Tuesday is a shared study guide. But this is an individual study guide where we kind of just copy and pasted each other's notes in our own thing. It's not that we can't work together. It's just literally sometimes, I don't know. It's not anything bad. There's nothing bad with it. But they get really self-conscious and they're like, oh, your notes look like this and my notes look like this, so I don't want to mess up your formatting. I'm like, brother, I don't care. I just need the information. As long as you put the information in, it's good. But we've had this conversation like a few times back and forward. So we just kind of decided that what works best for us and our study needs is that we'll still both separately create a study guide, but then we'll copy and paste from each other. So it's like, oh, this person did a really good job explaining this. Or hey, I simplified this information and put a chart, and I'm gonna suggest it over into your Google Doc, and if you want to add it, great. You know what I mean? But yeah. Evie says, huh? If I were to get more management reports structured like this, I'd be quite happy. Brothers, like peer pressure and be like, sorry, I can't accept this unless you write it this way. But yeah, my least radical opinion is that anyone arguing against patient autonomy should get a wedgie. Brother, I agree. What do you mean your patient can't decide what's best for them? Brother, I'm gonna kick your booty. But yeah, so number 1 was respect patients' values. Number 2 is the coordination and integration of care. So again, it's the idea that patients during these times are going to express that they're feeling vulnerable and powerless in the face of illness. And so that's why, it's really important to have proper coordination of care to alleviate those feelings. Patients identify 3 areas in which care coordination can reduce feelings of vulnerability, and it's the coordination of clinical care, so all the health specialists, let's assume at a hospital, the doctors that are talking to you, the nurses, the therapists, etc. Coordination of Ooh, this word looks familiar, but I don't even know how to say it. Huh? How to say? The past so many brothers?
Ancillary.
Ancillary. It's really funny because I only have like one brother. Brother! Anyway. Ancillary apparently means secondary and support services and the coordination of frontline patient care. Number 3, information and education can be very important in our patient-centered care because, again, patients express that they worry about not being completely informed about their condition or prognosis. It's really hard to be like, yeah, you have a heart failure, and it's like, what? What does that mean? I'm still alive, so if my heart failed, I should have been dead, right? Like, what does that mean? Like, you know? So it's really important to, maybe I should use another example, but, yeah. I'm moving on. Anyway, to counter this fear, hospitals can focus on 3 kinds of communication. So we can have information on clinical status, progress, and prognosis. So letting them know like, hey, you're doing great, sweetie. You're progressing so good. And because of everything you told me during your evaluation, your prognosis. So let me actually distinguish this really quick for Cubs who may not know. So a diagnosis is what you are, how do you call it? I don't want to use the same word. Categorized with. So let's say you have a stroke. That is your diagnosis. You have a stroke and you have this one-sided weakness. Again, it could be left, could be right, depending on where the stroke is. But your prognosis is because you were a relatively active individual doing their 150 minutes of aerobic cardiac workout. You have a good support system. You and your friends go out like every weekend to do walks around the park and all that jazz. You live with family who could take care of you. Your prognosis is looking pretty good. It looks like you have a really good support system and an active lifestyle that's going to help, again, maintain those gains that we're going to make during these sessions. And you're going to recover just fine in comparison to someone who's like, yeah, you don't even have a home. You're homeless. None of your family talks to you. You stay laying down. You have a very sedentary lifestyle. Yeah, no, I'm sorry, gamer. Your prognosis is not looking too good. And prognosis is not to say that you won't recover, but the likelihood of having a better outcome to get to like close or to full recovery, it's man, wow. Yeah, so diagnosis is just what the illness is, and prognosis is the illness plus your particular body conditions. I guess you could say that. It's just a like, what? Maybe there's a better way. Let's see. Prognosis is the likely course of a disease or ailment. Here, actually, this is a better word. The chance of recovery, basically. Whether you have like a high chance, a moderate chance, or a low chance of recovery, you know? My prognosis is also looking very good. I hope. I really, really hope. I think another word you can use, by the way, for prognosis that might be maybe a little bit more beneficial is like a prediction of like your outcome of your diagnosis. Maybe? Ooh, anyway. Anyway. Information and education! So yeah, information on the process of care of like, okay, patient, we're gonna be doing XYZ. And again, we need to facilitate autonomy. Again, patients have the right to choose what they want for their care. Just self-care promotion and just general overall health promotion is going to be really important as well. For physical comfort, what's going to happen is that what's really important for physical comfort is people's pain management. Are you helping them, you know, again, oh my gosh, you know how many people I ran into recently? And I'm sure people have their explanations and reasons, but there are a lot of people who I ran into recently who are like, yeah, I'm in pain, but I don't really like taking medication. I like to do more natural stuff. And it's just like, fair, I guess. I don't know. Sure. So it's the idea that you have to, it goes again with the autonomy aspects of like, okay, this is the person's like values, you have to respect that, and if that's a choice that they want to do, you kind of have to follow along with that kind of stuff, you know? helping them with their pain management. They don't want to take medication. Okay, find another way to try to lower their pain because, oh brother, you can't give them some Tylenol. To help assist with activities and daily living needs. So maybe again maybe they have a rotator cuff injury and they're having trouble getting dressed. This is not a physical therapist job, but maybe somewhere more like an occupational therapist of helping them get dressed, and with OT and how do you say it? And nurses helping them do their toileting needs, etc., etc., and just the general hospital surroundings and environment. I know a lot of people don't like hospitals because they don't like how sterile it is. I mean, I love how sterile it is. I mean, that makes me comfortable, but but the sounds and the beeping and everyone else looking like they're on death's door. I understand the hospital, and maybe people have like bad memories associated with hospitals. It's very cold, generally, Sterile, stop! At least it's kind of smells sterile. We can pretend. But that's no. But yeah, it's not your home. It's very cold. So for some people they don't really like that. So it's the idea of kind of warming it up and being like more intuitive of like, how can I make this more comfortable for you? It's another aspect we can implement when it comes to patient-centered care. Yay. Oh my goodness. STW, good luck with your task, gamer. Oh my goodness. Heck yeah, hospitals have always been peak comfy for me. Yeah, I felt so bad. So I had dragged one of my friends out when I went to the hospital before the awful hospital experience to get the referral to the ears, nose, throat doctor. And it was like a very small hospital that was nearby. And yeah, it was just really quiet. It was very clean. It was just a lot of beeping, and they were just so uncomfortable. They're like, oh, I hate hospitals. But they also had like a bad experience when they were younger, like with a family member. So I'm like, oh, I understand. But I'm like, this is nice. It's comfy. There's not a lot of people. They're not overworked. they're busy, but not too busy. It's fine. What do you mean? They're like, oh, the beeping is so annoying. I'm like, I don't know. I could just tune that out really easy. I don't know. The thermostat stays in my office, brother. I needed to always be a nice, comfortable. Let me convert this to my Celsius people. I think having it a cozy 23 degrees Celsius, 74 degrees Fahrenheit, pretty nice. Not too warm, not too cold. If anyone adjusts it any hotter, any colder, I will cry. It's all fine and dandy until you encounter the liminal space hallway. You're back to Tipanya. I was just talking to Terry about this the other day. Hold on. Gosh darn it, where is it though? Wah, I can't find it. Oh, I found it. Yay. Why is it so small? Ta-da! Liminal space. Wah, wah, wah. 23 has you sweating? Oh, okay, sorry. 21 degrees Celsius or 70 degrees is also fine. Oh my goodness. Eh? Bruh, wait until you see the lady in black at our night shift? I don't want to be involved in any kind of horror stories like that. What do you mean the lady in black? Our uniform doesn't allow us to wear that. Oh my goodness. STW, thank you so very much for the 5 stream streak, Galmer. Thank you. Can't wait to somehow miss a stream. Oh brother, now you can't. You're locked in, as the cool cups say, right? No worries, Galmer. Thank you so much for the support. Thank you. 16 degrees Celsius tops? Ugh, okay, what's 60 degrees? 60 degrees Fahrenheit. Fine. Any colder though. Any colder. I'm not having it. I could take 60 degrees. Hi Apple, hi gamer, Galmer. Welcome on in, welcome. You already dropped 2 streaks? I'm sorry, Galmer. You'll just have to keep your notifications on Twitter, and you'll have to keep how do you call it? You'll have to just be really dedicated to the Discord. You'll have to put my Discord on #1, and you'll never lose a streak, okay? Oh no! Galmer. Robo, thank you so much for the thank you so much for the 75 stream streak. See, that's a good temperature to be at. 75. Where am I? Where am I reading numbers? Thank you so much for the 75 stream streak. What a comfortable temperature in Fahrenheit too, right? Right. I live here, brother. Same here. Howdy, neighbor. But thank you. 75 times over. Thank you. Another wrinkle in the book to be like, gosh darn it. Didn't the streams wait? What? Wait, stop. Hold the phone. No, I don't know. Maybe I should. I'm like, wait, I'm trying to do math here. I'm like, when did stream streak start? And I'm like, did it start this year? And then I'm like, damn, have I been streaming 75 times this I can't believe I streamed 75 times. Yeah. But I'm like, no, I think it started late last year. So actually, never mind. I take everything back. Because I was like, that's crazy. I'm trying to do the math. But I'm like, I only stream 4 to 5 times. I'm so sorry. I take it back. I'm sorry I said even the word only. I tend to stream 4 to 5 days a week. And I'm trying to do the math. And it adds up so fast. But yeah, hello. Welcome, gamer. Thank you so much for the head pats. I'm sorry. I wasn't avoiding it. I just literally was not tall enough. I guess I'm normally much taller. But I feel like if I make myself any like bigger, then I become unproportionate for my hands, you know? Anyway. Gamer, thank you so much though. Thank you. Oh my goodness. I did have a lot of double streams, you're right. Oh gosh, I did. No, I'm not tall enough. Thank you. Thank you for the headpad. Thank you. I'll just move the headpads because I'm already blocking chat. What? Oh my goodness. You're so right. I don't want to do that, man. But that's crazy. Thank you so much, though. I can't believe I have a neighbor here in Bearcat Mountain. Let's go. Let's go. Karma says I could take 16 degrees Celsius if there's sunlight coming in, but something about it makes it bearable. Gosh darn it, what's 16 degrees? Oh, 60 degrees Fahrenheit. Okay. Yeah, again, the sunlight has to be there. If the sun is out, great. If the sun is not out, brother, I'm wearing layers. I'm already kind of wearing layers at 21 degrees Celsius or 70 degrees, but listen, I don't retain heat that well. I need those layers. Like right now I'm wearing a sweater and I'm sure in my little home it's only like 74 degrees. So I'm kind of like, I am gonna take the sweater off though soon because I feel like every time I talk to stream I get like embarrassed or something. I get too warmed up. I'm just like, my body heat has increased because I'm talking to chat. So I'll do that during break, but I have to get through these 8 principles of Picker's silly patient care model, whatever. I don't care. Okay, number 5. Emotional support and alleviation of fear and anxiety. Yeah, so people have these and you should pay attention to them. You should pay attention that patients may have anxiety over their physical status, treatment, and prognosis. They may also have anxiety over the impact of their illness on themselves and family, and really a main one, anxiety over the financial impact of the illnesses. Cubs, I'm not kidding you when I tell you. I think I would have owed, what did I say? It was either 25 or 30,000 for my little overnight stay at the hospital outside of Bearcat Mountain. And I was horrified. I was like, brother, I have never made 25 or 30,000 in a year. I told you guys with full transparency that I made what I made last time. So it's just like knowing like, oh yeah, that's like 3 years of income. It's like, what? A healthcare system, at least in the US, kind of wonky. So yeah, of course there's gonna be anxiety over that. Holy heck. All right. Number 6, involvement of friends and family is going to be important with the patient care model. Again, providing accommodations for friends and family. Having close friends and family may be involved in the decision making. Obviously, the patient at the end of the day will make it, unless, they're unable to. How do you say it? Supporting family members as caregivers, and just recognizing the needs of the family and friends, because it's one of those things that we're all in this situation together. Yes, your patient's going to be in the center, number one, but it's also important to address some of the stuff that we're talking about with this patient-centered care, such as information and education to the family and friends if need be, but you also have to keep account of HIPAA. Again, it's only if the patient, wishes that's the situation, but it's good to keep them in the loop, because again, if they're the ones who are going to be taking care of this patient, when you no longer see them in a few weeks or a few days, it's kind of like, oh yeah, here you go. Anyway, number 7, continuity and transition. Patients express concerns about their ability to care for themselves after discharge. Meeting patient needs in this area require... I can't read. Hold on. Meeting patients' needs in this area require the following: understandable, detailed information regarding medications, physical limitations, dietary needs, etc. So this is just, hey, these are the medications you were prescribed in the hospital that you should keep up until either symptoms resolve or, depending on the situation, maybe for life. Physical limitations, maybe there's some precautions, maybe they are post-surgery and it's like, oh, you just got a hip surgery, no BLT, no bending, lifting, or twisting. Maybe some dietary needs. Again, maybe they're placed on a certain diet, maybe they had some heart condition and maybe or something with their blood pressure, and now they're on a low sodium diet that they should probably continue after discharge. Coordinate and plan ongoing treatment and services. So again, we talked about like outpatient services. Can also talk about home health, etc. It just, again, depends on what the patient needs. And provide information regarding access to clinical, social, physical, and financial support on a continuing basis. Because even though you are no longer going to see them, you're putting them, or you're setting them up for the next steps of what to do going forward. And again, a lot of people just won't have this information in hand. So allowing this transparency to be like, this, and this are your resources moving forward will just mean a world of difference to your patient, And then last but not least, access to care. Patients need to know where they can access care when it's needed. Focus mainly on ambulatory care. Following areas were of importance to a patient. So knowing the access and location of hospitals, clinics, and physician offices. Again, like I mentioned earlier, I don't have a PCP or a primary care physician, but knowing the ones in my areas, the ones that will treat whatever I need, very important, especially if maybe someone who would be like me, where it's just like, yeah, you should probably follow up with your primary care physician. It's like, well, I don't have one. It's like, okay, here are the ones that are taken by your insurance. Oh, you don't have insurance? Okay, these people take it without insurance, but they have like a sliding payment scale, so you can use these doctors instead. Having that kind of list of resource really made like the process and transition easier, at least for me to be like, oh, okay, now I know. Availability of transportation, huge, because a lot of people who tend to have these health problems actually don't have a way of getting around, or maybe they don't feel comfortable driving, and then again, they don't have that friend or family member who could take them around. So there's actually some clinics that will actually have like a little van that will drive over to the patient's house, get them into the van, and get them to their appointment, which is really nice. Ease of scheduling appointments, availability of appointments, accessibility to specialists, and then clear instructions provided on when and how to get referrals. So, yay. And all that, again, is going to be a part of our Pickers? Yeah, Pickers 8 Principles of Patient-Centered Care. Yay. Alright, so the next thing we're going to move on to, which will be a little, I feel more interested or more passionate about, is going to be about healthcare models, theories, and frameworks, and how we're going to be able to apply them, okay? But let's take a little baby break because we're approaching the 2-hour mark at this point, and then I can come back refreshed and we can get through these pages, because right now we are now page 7. Woo! Out of 42! Yeah, boy! So we'll see how that goes. But yeah, one moment comes. BRB! Da-dang!
かすかに響き渡る教会のチャイム、祈りを捧げ今日を裏切る。暗い森の中をさまよって暗絶の壁な残月になるの。透明な嵐に待ち出す甘い淡い蜂蜜でもっとベトベトにした。お願いいい子になるから私を承認して。風に舞う絵本のページが影になって記憶を揺らすの。ずーっとあの場所で待ってるから。空っぽの世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて。花びらがゆっくりと二人を包むよ星の夜に。ねえね迷い込んでしまった出口のない迷路、ぼんやり口ずさむ同じ聖書。秘密の呪文ちぎるようにオルゴールが静かに歌うの。透明な嵐に待ち出すに弱く荒く噛んでもっとぐちゃぐちゃになったら。お願いいい子になるから私を承認して。絡め合った恍惚な時が重ね合ったあの日を照らすの。ずーっと私はここにいるから曖昧な未来であって何も怖くないよ。差し出された手に触れて高まった糸が優しくほどけた。不条理な傷でって舐めてあげるから星の夜に。ねえあの森で待ってるからあの場所で待ってるから。あの場所で待ってるから空っぽの世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて。花びらがゆっくりと二人を包むよ星の夜に。ねえねえね
Gamers, I'm back! Sorry. I hope you guys had a good break. I probably should have said it for like a set amount of minutes to be like, alright, 5-minute break, go! But I was like, look, if I could do a little lap, I pet baby peas, I chug my coffee, I look at the outside being like, beautiful day, and close the curtains immediately right back, I had a good break. So let's continue on, okay? So the next things are gonna be not as dry, thankfully. I'm not that I'm passionate about the models, but I feel like they're a little bit more interesting to be like, treat your patient with respect. And there's some other things that I feel like are, again, just a little bit more easy, and that's something that I'm looking forward again to, how do you say it? Working through together with you cubs, okay? So, thank you for the welcome back. Thank you, thank you, thank you, thank you. Thank you for the headband. Thank you, thank you, thank you. Oh my goodness. Glad you found time to pet baby Peas. Thank you. She's sunbathing right now. What an absolute angel. Anyway, so these models are really interesting because they are talking about how we could apply them in what do you call it, healthcare, but it's the idea of like the individual, so the patient or me or you, and how we kind of process this information. There's different models. It depends on which one you really want to take in, and there's actually several, so please forgive me as we go through all of them. But yeah, let's try to go through them one by one, okay? So the first model, which is actually a relatively popular model, I feel like it is applied in most healthcare places, is called the biopsychosocial model. And this is the inclusion of all social, with social including family, friends, etc., and psychological aspects such as depression, anxiety, etc., and the health. It's the idea again of treating the patient as a whole person, not just for their condition. This is what we consider to be multimodal, or it's like a reference to something so funny. Anyway, it's a multimodal or interdisciplinary approach. So again, it's not just you as maybe like a doctor. It may be you and a psychologist, or you and a therapist, or you and some kind of specialist to see what we can do to take care of this patient. Because you know what? Even though this patient might be here for, again, rotator cuff is so popular right now. Let's use wrist pain. Let's use wrist pain for example. Someone has carpal tunnel syndrome. We're all super gamers and we don't have proper posture of our wrists or something like that. It is shown in research that to alleviate this pain that we might be having, or the symptoms we're having of carpal tunnel, yes, it is important to go ahead and address it. But if we tackle the other two, we just don't tackle the musculoskeletal, the biological issue. We also tackle the sociology and the psychological aspects, that we're going to have more of a successful outcome when it comes to tackling the pain. How? Read the research paper. No, I'm just kidding. But that's a model that a lot of people tend to follow. And again, it's just, again, how do you say it? There's been more of a move or an approach for a lot of other professionals to work together, and it's the idea of further combining that and further enforcing that concept and idea that's like, hey, we're not all individuals, we should all work together to make sure that this patient has the best care possible. Let's talk about another model. So this is theory, or well, it's not a model, it's a theory, but let's talk about the theory of planned behavior. So this is really interesting because this is like, hey, I'm gonna make a lifestyle change. I'm gonna start taking daily walks. And it's the idea of like planning this behavior of like, yeah, this is something I really want to do. Well, let's use that for example for our theory of planned behavior. But we have to consider the patient's attitude, the subjective norms, which are things that are just like socially acceptable, and perceived behavior control about what could I as the patient do about this situation. So processing both the attitude, subjective norms, and what control I have over the situation, that's going to help me make a behavioral change, and in this situation make a healthy behavior to truly make a change and sustain that change. So kind of weird, but we can break it down into attitude. Look, I have a positive outlook and a positive attitude in general, and outlook that, hey, I think these mental health walks would not only just help me physically, but also mentally, maybe even emotionally. I think taking a walk around my community is relatively socially acceptable. I see a lot of other people do it. They either walk their dogs, or they just walk with their families, or they take little walks by themselves. And hey, you know, I could walk. My two legs are functioning for now. I can go ahead and do it. Yeah, I think I'm gonna go ahead and try to do that. And then again, that's gonna help me process and make that healthy behavior. There's actually another theory or model that we'll talk about that will kind of reinforce this theory. We'll talk about it. I think it's like 2 or 3 models down. We'll see. Yeah, speaking of changing your behavior, yay! Behavior change wheel. So this is really interesting because this is the model right here. It's a little overwhelming, so I'm not gonna go over it, but it's the idea of how versatile it is when it comes to treating the individual to maybe some more like something more like the community, something much broader like that. And it's the idea of what would be more appropriate for the desired outcome. So let's say there's a group who is really motivated to have a physical fitness. That's like their new goal. Like, hey, I want to live a less sedentary lifestyle. I want to get more physically active. I have a few friends, you know, maybe I can involve the community and bring awareness to like this disorder, or like maybe the signs and symptoms that are associated with having a sedentary lifestyle. And if we do all this, a little bit of healthy activities as maybe like a group or class, then, you know, these will lessen our chances of getting these signs and symptoms, and we lead a quote-unquote healthier, better lifestyle. Well, how can we do this? And it's basically kind of peer pressure. It's the idea of getting more people involved, getting these interventions to be like, hey, LMAO. In this example that they used in the lecture, again, it's just having those fitness classes and having them at a regular time frame, and then it's almost like a snowball effect of like, oh, these people are doing it, getting others involved into it, and then it's like, oh, these other people are doing it, and they're most likely going to adapt to that lifestyle change and have that behavior change. Guys. You're gonna collect all the symptoms? Don't do it! Don't do it! But yeah, so behavior change wheel varies. Theory of planned behavior, it's again, hey, what can I do to control my life, and is it normal to society? Sure. And biopsychosocial, basically break it down in name. Biology, sociology, and psychology. Yay, all that's involved in my health. Yay. Anyway, basically shame people into having a healthy life? Yeah, basically. And it's like, huh? What? Anyway, this is really interesting. I didn't think I read this one as much, so apologies. This is going to be the first time of me really reading this. So, health behavior model. So, for this model, this is going to be a combination of demographic and psychological characteristics. So, this has several aspects. We could talk about... Excuse me. Let's talk about it based off the model. So this is a combination and extending from here. So what are demographic variables? This is going to be your class in a sense of like, are you lower, middle, or upper class when it comes to maybe finances? Your gender, your age, etc. While psychological characteristics are your personality, maybe we could break it down to, hey, are you more of a type A or type B kind of person? Are you type A, like a kind of go-getter, go, gotta do this, I'm really stressed out if I'm not doing this, I'm doing nothing with my life, and oh my goodness? Or type B of like, kind of go with the flow? Are you prone to peer pressure? Stuff like that, and then it goes out into these different characteristics, so let's talk about them in order from here now. So, perceives susceptibility. This is the idea of how much a person believes that they're likely to acquire a specific health condition. So, I don't know if it's appropriate to say this. Okay. So, as you guys are familiar, there's some disorders that are just like more prone to others. It depends on their health conditions, their lifestyles, their dietary needs, etc., etc. I think when COVID was, very early in the stages, I feel like a lot of younger people, not the card away. I'll finish it. If it gets me canceled, I'm sorry. But I feel like a lot of, younger individuals, I guess people less than the age of 50, I would like to say, weren't really worried about COVID because they're like, oh, this is like an old people's disease. Only older people are gonna get this, so I shouldn't have to worry or not take the proper precautions. So it is an example of perceived susceptibility where maybe a lot of younger people, let's say Forever 17, but not me in Pacific, it's just like, yeah, I'm most likely not going to get this disease, and so I don't really have to worry about it, because then we go hand in hand with perceived severity, where it's like how truly this disease is. And it's the idea of like, well, I don't think I'm gonna get it, but if I did get it, it'd be pretty bad. Exactly, if you're under 55, you're young? Yeah, no, honestly, I feel like we have this whole talk now. I think once you hit like a certain point in your life, age doesn't really matter anymore, in a sense of like, oh my gosh, I'm so and so age, I'm so old now. It's like, no, you're not. I think even relatively, how do you say it? My mama bearcat, again, I saw her the other day and she's 70. Oh my gosh. I'm like, Mama bearcat, what? But she looks so young because it's just how you make your life. And what you do with your life really makes up everything in your experiences. And I'm not saying 70 is necessarily young because she's so funny because her new neighbors, she's like, yeah, they're like seniors. And I'm like, Mama bearcat? No offense. I think what do they say? Like if you're over the age of 65 or something, you're like a senior or something like that. Mama bearcat, you're classified as a senior. I don't know. But I've had some people in high school who's like, yeah, once I turn like 30, I'm gonna like not be alive anymore. I don't want to get old. I'm like, brother. What's happening? I don't get that kind of lifestyle or mentality or anything like that. They only have a few years. Oh my goodness. But yeah, I'm old, but I'm a 400+ wagon. Handshake. Handshake emoji. I'd love to continue this conversation over tea once exams is over. Yeah. Since when is 30 old? So what do you call it? 30, what do you call it? I feel like this is like a very common conversation you have more in high school, but I still had other people, and I think this actually kind of popped up in my feed recently about like, oh, when you hit 30, you're like old, and I'm like, what? There's at the clock, what? Oh my goodness. Another Mama bearcat, we're Hispanic. Mama bearcat, you're a senior. But I don't know. Big shrug emoji. I think, look, listen. Until you hit the age of 65 or older, then you're old. Then you can be like, oh yeah, I'm kind of getting there. But being old is not necessarily a bad thing. But again, it's what you'll make of life and how you make your experiences and blah, 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 blah. As long as most of everything is functioning, you shouldn't be fine. Not old yet, let's go! I'm sorry to any cub who's 65 years or older. I want to formally apologize. Do not cancel me. I'm just literally saying. But yeah, that was a loop of a conversation we definitely had. Anyway, general health motivation. So basically their motivation to live a healthier lifestyle is also in the health belief model. And then perceived benefits. Perceived benefits is a person's belief that their anticipated behavior change will have some sort of positive effect, like my walks. Like, oh yeah, I'm not as stressed out anymore because I look at grass and I breathe in air that isn't just circulating around my house. Amazing. And perceived barriers. I don't know why I don't have it copy and pasted. Perceived barriers, I'm just gonna assume that it's in reference to barriers in making that change and if you can overcome them or not. I think that's pretty self-explanatory, but in case it's completely wrong, well, good luck me on the midterm in a few hours, you know? Can't wait to get 30 for strength buff. Same. Let's go. Hi Milty. Hi. Welcome. Gamer. Welcome. All right. So that's that. So that's the health belief model. It's basically like, ooh, do I believe this will impact me? And how will it? And here are the factors involving this. Woo. All right. Now this is where it's at. Honestly, thank you so much for that. Man, I have to move my head pads. It's like a nice head scalp massage. But thank you. I'm glad that they're more consistent here than they have been for the past few days. That's always good. But brother, where are my head pads? Hold on. I'm looking. Why do I have so many windows? Where are the head pads? I can't find it. Oh, I found it. Let's see. One moment. They're normal now. Thank you for testing them. Thank you. Cassie says good luck on the midterm. Thank you, gamer. Is this a class stream? Yeah, I force you cubs while they're gunpoint to hear me talk about my midterm stuff. Can't theoretical model change. Stages listed also include potentials to relapse. Yeah. Basically, welcome to class. We're 2 hours in. I hope to be done in 4 hours. Because my exam is at 7. Alright, let's speedrun it. Anyway. Trans-theoretical model change. So this is actually a fun little one that actually starts right here in pre-contemplation. So this is the idea of, hey, I want to make a healthy change in my life. I want to change something about my life. I'm thinking about it, and it's something I'll probably do within the next year, or half year, or within the next 6 months. And it's just thinking about your health, of the pros and cons. Like, do I get that gym membership? And you can say, nah, because you don't want to pay $20 a month. And you're like, yeah, I'll just go on walks, it's fine. Then from the pre-contemplation, because we know pre is a prefix for before, we go into the contemplation phase. And for contemplation, this is now within the 6 months. Only $20, I wish. Sorry, Galmer. I know there's some high-end gyms out there, and I'm picking the cheap one, you know, but still. I know there's more expensive gyms. I know. Oh my gosh, I think there's a membership for over like $100 for like the really fancy ones. I could never. I would just buy the equipment at the spot. I don't know. Oh my goodness. No, you didn't, Weave! Wave says, hi, now that I think about it, I completely forgot about telling you that I did pass the entrance exam for college this I can't read! Weave, congratulations! God heckin' congratulations for passing your entrance exams! Gamer! Are you so excited to be a college student? Are you so excited that all your hard work has paid off? All the geometry? That maybe only had like maybe 2 or 3 questions on the whole entire exam paid off. But good job, gamer, good job. I wish you many more successes and passing many more exams and getting to wherever the heck you want in your career and life, gamer. December, 2 months late. What the heck? No, I'm just kidding. But I hope you've been living a good life and you're continuing to live your best life. I'm so over geometry. I'm sorry, gamer. It's okay. It's all over. It's all over. Unless you have to take it. Do you? No, you don't. I mean, obviously, my area of Bearcat Mountain and like where you live are different, of course. But yeah, I don't think you take geometry anymore. Yeah, I think it's only entrance exam stuff, and the only math you might have to take, maybe, is like statistics or something. It really just depends on what major you're going for and how they may have put your undergrad stuff, you know? It's all over until you need to use it later. Truly. The only time you need it is for your 360 no scope. Oh my goodness. But yeah. Okay, contemplation. You make the change, but you haven't made the change yet. But now you're like, okay, within 6 months, I'm gonna make this change, and it's really beneficial with encouragement. People or your friends are like, oh yeah, that sounds like a great idea to do this stuff. Go ahead and do it. So then you go ahead and do it. So then you move into the next phase. Just preparation. And preparation, that's going to be within the next 30 days where you make small steps. And again, support is very important for this one to kind of keep you on track. Then we go into action. So now it's within the 30 days, you're starting to do the action that you want. You're like, yeah, this is the thing I've been pre-contemplating about. Yeah. So it's the idea of actions, and what's really important is that you have to be consistent with it. And once you're consistent, it's basically keeping up that maintenance, you know? How do you say it? This model is really interesting because, I mean, yeah, sure, it makes sense. Sure. This model actually allows for relapses, so not everyone is perfect, you know? Sometimes it's like, yeah, I'm so ready, I'm so prepped to make this change. I'm gonna go into a gym. Oh no, something happened. Maybe I fell and it hurt and I don't feel like working out. Alright, I'm back to contemplation. Hopefully in the next, 6 months, I'll feel better and then we'll get back into it and then we could start this cycle. That is the idea of this. And it's not that necessarily every relapse has to be like you hurt yourself, but like it can also be a mental thing too, where it's just like, actually maybe I'm not ready, you know? Maybe I'm not that dedicated. You know what? Pre-contemplate now. But yeah. Let's move on to this last one really quick, because this one, didn't have anything. It just said the fusion of innovation is the model. It said that it was a theory popular in the 60s and that was popular for public health, and that it involved innovation of itself, communication channels, time, and social networks. Now, it did not explain what any of these categories meant or the 4 elements. It just gave me this picture, said 4 main elements, and that's it. So I'm like, what? What? Okay, whatever. Anyway, we'll move on to learning theories, which is actually pretty fun. So we'll see that in a little bit. Weeb says it's going for mechanical engineering. It's 100% coming back somewhere somehow, but that's future Weeb's problem. Gamer, don't worry about it. I think you'll take another math. It's fine. It's okay. No worries. I don't know anything about engineering. But good luck! Good luck, Ember. Take a little baby break before they throw you into classes. Unless you're already thrown into classes, then, well, heck. Sorry, gamer. Oh no, my little... Oh, wait, it switched? Oh, gamers. What? Gamers? Hold on, gamers. Alright, now let's move on to learning theories! Yay! So before those were health models and health theories? We'll see. But now we're going to talk about learning theories about how people actually learn how to do stuff. So we could talk about this in several different approaches. So let's go on and talk about behavioralists. Behavioralists? I hope I'm saying that right. How do you call it? This is a really popular one that I'm sure you guys have heard about in like your general psychology course that you may have taken in high school or in general education, etc. But basically, behaviorist is just a change of behavior. A really common example that you hear about this is Pavlov's classic conditioning, where it's the idea of like, hey, actually, let's just run through the picture really quick. So this is before conditioning. So we have a dog who's salivating because they see the food. Before conditioning, there's a tuning fork, which has nothing at all to do with the food. And so the dog is like, that's not food. I'm not going to salivate. But while we're trying to condition and change the dog's behavior, we're going to present the dog with food, and we're also going to ring the tuning fork. And so now that the dog is like, oh, I see food. Oh, I'm also hearing this noise. I'm starting to associate the noise with food. I'm going to start salivating. And then after proper conditioning, how do you call it? Every time you hear the tuning fork, now the dog will start to salivate. Yay. Thanks, Pavlov. Oh my goodness. Maybe they spent so much time doing that he considered the tuning fork? Yeah, like, yummy tuning fork. There's actually a really funny comic, but I don't know if I have it available. But yeah, conditioning? Kinda crazy. But yeah, that's a change in behavior. So for humanists, oh my gosh, everything is so thrown off. No! There. So now we'll move on to humanists. So humanist is the idea of a personal active field development or maturation of a person. And I'm sure you guys have seen this chart of Maslow's hierarchy of needs. This has actually been memed around to heck and back. Where it's like emo girl on top or something like that. But this is like a pyramid of like your needs that you have in itself, and it starts from like your foundational basic ones, your foundational ones being like the base of the pyramid to going up high. So from the bottom to the top, we have our physiological needs. So air, pretty important, water, food, shelter, sleep, clothing, reproduction, sure. Above that, it's going to be our safety needs. We need to feel secure in our personal security, our employment for financial security, resources to help us, our health, and our property. Love and belonging in the middle right here, our relationships with other people, whether it's friendship and intimacy, family, and a sense of connection. Esteem will go above that, and your esteem is for the respect for yourself and others, self-esteem of how you value yourself, your status, your recognition, your strength, and your freedom. And at the very top of this pyramid of the maturation and self-fulfilling personal needs and stuff, it's going to be self-actualization, which is the desire to become the most that one can be. So yay! That is the humanistic approach, or humanist approach, of having these, again, Oh my gosh. Personal acts to fulfill development. Alright. Cognitivist. Oh my goodness. It's brain. It's cognitive. It's thinking. So the cognitive learning theory is related to information processing. So it's a little more robotic, I guess is the best word to say it. It's not as human. Hence humanistic versus this cognitive business, but we can use Bloom's taxonomy for it. So same thing with the pyramid, starting with the base and then going to like the most narrow. We could recall facts and basic concepts. Again, that's anything we do in information processing. If I told you, Cubs, a fun bearcat school fact, like, hey, you have bones, it's like, yeah, Tippa did say we have bones. And so this is going to help recall facts and basic concepts, which is going to help you define, duplicate, list, memorize, repeat, or state. Also kind of what I'm thinking for studying. But we need to understand this concept. We just can't say things and be like, yeah, hueso. And it's like, where did I hear that word again before? How do I explain bone to someone who's never, or hueso to someone who's never seen that word? Oh, hueso means bone. And as you know, we have bones in the body, so explain ideas or concepts. So use that information in new situations and be like, hey, Cubs, did you know your bones can break? And it's like, wow. So we can, anyway, I'm just gonna keep going through this. We have bones? Why did no one tell me this before? Exactly! Anyway, it's fine, it's fine. So, apply to use this information in new situations. Then we'll analyze, so we'll draw the connections among ideas so we can differentiate between maybe different bones. We can organize knowing that we have different types of bones, like especially in our spine. We have like the cervical, thoracic, lumbar. We could compare and contrast, etc. We can evaluate or justify a standard decision being like, yeah, bone's pretty great. And then you know what? At the end of it, we can produce or create original work from this now that we're getting such a good understanding of bones, you know? Which is going to help you design, assemble, construct, develop, formulate, or investigate. Hey, what are bones? To my understanding of everything else that I've done previously, let's create something new. And that's how we could be more cognitive in our approaches about processing information. Not everything has to be here. You don't have to create new pieces of work, but it's just the higher levels of understanding. 3D? Bones? New money-making idea? Basically, I replaced your spine with this. Bonus device, look inside. Bones? I would want a refund. You said this was a boneless device, but there's clearly a bone in here. Robo says at first I didn't believe in bones, but then Tepper presented me with undeniable proof such as you have bones. Brings out the spine model. This is your spine! But it's fine, it's fine. Social cognitive. So okay, cognitivist, whatever, is very information processing. So let's talk about socially. Socially is very interesting because this is interaction and observation within a social context. So this is not as black and white. This isn't me just stating facts. This is just something you pretty much gather, within your community, within, how do you say it? Social norms with maybe friends and families. So we can use Banduro's social learning theory where it becomes attention, retention, motor reproduction, and then motivation. So stimuli, rehearse it, practice it, and you get a reward for it. I thought I had another picture, but I guess I don't. But yeah, social, ooh, society, the one that we live in. And then last but not least, we have our constructivist or social constructivist learning theory, where this is the construction or meaning and knowledge from experiences. So similar to social cognitive, but this is not learning from like your mom, dad, or family members or friends. This is that, but how do you say it? From experiences. Sorry, it's like, oh. Hi, welcome on in, camera. Welcome. So for this one, we could pretty much start anywhere, but let's start from here. Let's have a concrete experience of doing or having an experience. Reflective observation to review and reflect on that experience. Then abstract conceptualism or conceptualization is where we learn from that experience. And then we have active experimentation of planning or trying to learn or sorry, trying out what we've learned, and then it kind of just repeats. Having an experience is a cycle, apparently. And those are your learning theories. Gosh darn it, that's probably gonna be like one thing on the exam. Anyway, now let's move into something more healthcare related, okay? Let me just take a quick sip of water though, because gosh darn it. Okay, so let's talk about I just drank water. Thanks for the hydrate, gamer. But let's talk about something more medical. Let's talk about, how do you call it? Medicare. So Medicare and Medicaid is words that you'll see frequently thrown around in the U.S. healthcare system. It's a mess. It's actually really messy. But Medicare is actually broken down into 4 categories. And it's broken down to A, B, C, and D, which we'll just talk about in just a moment. Huh? Amanda says, do you know a bit about the French sociology or family theory? Oh no, unfortunately I'm not as familiar with that. We were just talking about learning theories in healthcare. I think psychology and all these kind of theories are really interesting, but I never pursued them to higher education, so Gomena Sawi, I don't know. Asa says a more fact learning style? Yeah, I would hate to learn not facts. But anyway, so Medicare A, B, C, and D. There's like very shortened versions of how to like separate it, and thankfully, I don't know. They kind of correlate to their letters, so yeah. Let's do our best while trying to go through this, okay? So Medicare A, this is for acute care, so this is for hospital care. This is for someone who, you know, got into an ambulance and we're throwing them into the hospital. This kind of Medicare A, this is only used for acute treatment, and when we talk about acute treatment, it's returning patients to PLOF, or prior level of function only, and this can include not only just hospitals, but it can include skilled nursing facilities, which we talked about earlier, inpatient, which again are hospitals, and hospices. So they don't do anything to improve. It's just like, hey, you're medically stable now and you're able to kind of walk. You weren't able to do that before? Great, get out. Medicare B is for the best that the patient can be. So not only are we bringing them back to prior level of function, we're actually going to help maximize their function. And you can see this a lot in outpatient care, preventative care, and home visits, where it's like, yeah, I know you have the basics to do this, but you can do better. Basically, we're going to get you to doing maybe some of the goals that you had in mind, like, oh, you can walk, but you want to start running a marathon? Gamer? I got you. Medicare C is really interesting. They only summed it up saying that only children get, what do you call it? It can be treated or approved for this plan. But then they say all this stuff. But then they also say they get A, B, and also D. So it's like, what? Huh? But anyway, C is for children. That's basically where I'm gonna leave it right there. And Medicare D is for drugs. So this is going to be covering outpatient prescription drugs and anything with the Medicare Advantage plans with drug coverage. So yay! A for acute, B for the best you could be, C for children, and D for drugs. So yay! But then it's like, hey, I helped this patient and they were Medicare B. How the heck do I get paid? And it's a lot. Oh boy, it's a lot. So I'm gonna skip a little bit and we'll talk about here. So this is how people are paid. So you can't just say you helped the patient. How specifically did you help the patient? And it's like, well, I helped them walk. And it's like, okay, but how did you do that? What's going on with the patient? What is their diagnosis? So when you're doing billing, what happens is that you have to assign codes. And what happens is that even if you do this basic, like, oh, I assigned a code and it gave a detailed explanation about what's happening, what's gonna happen is that in an ideal world, they'll just take that information. It's like, oh, you did do XYZ and here's the proper coding for this. Yep, approved. But most of the time, they may do an audit. And whether that's going to be post-payment or prepayment. I don't know how they do pre. Again, I'm completely new to this. But yeah, so how do we assign codes? So let's actually talk about this a little bit after, and I'm going to catch up with chat in just a moment. But when trying to do billing, there's two types of codes that you would use. You would use either the ICD-10. -10 is to represent that this is like its 10th edition, or I guess you could say edition of this. And then we can use CPT codes, and they both do different things. So let's talk about that in just a moment. But Manny says, me with the glass bones disease. I would say, yeah, kind of. Oh, gamer, I'm sorry. Asa says, you're able to walk? Patient, I couldn't before? Oh, grabs hammer. I need to fix this. This is prior level of function after all. Gamer, they would kick my booty. They would be like, you should do no harm to the patient and be very honest with documentation. I'll be like, huh. That's okay, it's okay. So let's start with ICD, and I think I have a little bit more details here. Yeah, I do. So the purpose of ICD is a type of code that stands for International Classification of Disease, and this is used to track the disease, the statistics, the signs and symptoms related to the disease, abnormal findings, social circumstances, the external causes of injuries and diseases, quality outcome, morality statistics, and billing. While the CPT code is for current procedural terminology, and this is going to be much simpler, and this is going to be used to describe tests, procedures, and evaluations. So a quick summary in table format is that ICDs are used to describe the disease or injury, and we can see right here an ICD is a presence of right artificial hip joint. So this person recently got some type of hip surgery. So that is something that we would use the ICD code for. ICD codes tend to be 7 characters, so they're 7 digits in length. And normally they begin with some kind of letter, and then they're followed by 2 numbers. How do you say it? The first 3 characters represent the category, which describe the general type of disease and injuries. And normally when you see a decimal point after it, it's to describe a subcategory. So let's go back here to medical diagnosis. Here's our 1, 2, 3, 4, 5, 6. So this is 6 characters, so I feel like I've been lied to. But here are 6 characters. And we have this dot right here, or period. Anything after this decimal point is going to be a subcategory. But this main thing, Z96, is to indicate presence of right artificial hip joint, while this is maybe a more specific thing to be like, oh, it's the right side rather than the left, or some other thing. I'm not as familiar with the codes, and thank goodness to heckin' back they don't expect us to memorize the codes, but it's the idea of how do you say it? It is the idea of like, hey, but you still need to get these proper namings for this, so it's more easily billable and that you get paid for the service that you provided. So ICD describes disease and injury, while CPT codes is going to describe the service or the procedures. So these are typically 5 characters or 5 digits, and that's again going to represent the procedures and services to the patient. Some of them begin with a letter followed by 3 numbers, but a lot of them are going to be like straight 5 digits, and we can see them right here. Yeah, a lot of people who get hip surgeries tend to be older women because of their that they're prone to osteoporosis, or the bones breaking down. So it's kind of like, oh, your bone's breaking down here and it's causing some pain and conservative treatment's not working. Yep, gotta put you through surgery. Sorry, ma'am. Boop. And then they feel better, I hope. Results kind of vary, unfortunately. Most of the time they feel better, but there's some people who are like, this was awful and blah 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 blah. But there's a lot of variety of factors playing a part of that, so I don't know, gamers. Anyway, so CPT codes, let's describe the service and procedure. So ICD is describing the disease and injury, so we have the presence of a right artificial hip joint. So our treatment and services we're going to provide, hey, we're going to do R29.89. This is going to be the CPT code for abnormality of gait and mobility. So if this is our treatment diagnosis and what we're aiming to do during our session, what is the service we're going to provide? Well, the service we're going to provide is going to be 97116, which again is another CPT code. These are both CPT codes. And this is going to be for gait training. Gait training, again, gait is just a really fancy way to say walking. And that's going to be it. Again, how we differentiate between ICD and CPT is that CID, again, is going to be the diagnosis, while the treatment and services are CPT, okay? Now, speaking of CPT codes, we can actually go into detail about what is the level of presentation that the patient presents as. And there's like a lot of weird correlations with it. I think this picture down below does explain those correlations though, you know? How do you say it? Let's see. Therapists must use 3 evaluation codes and a new re-evaluation code. The new evaluation codes reflect the 3 levels of Sorry, I didn't read that. 3 levels of patient presentation. Okay. So there's a new code in town basically, and what happens is that these codes are to describe what the patient is presenting as. So are they low complexity, moderate complexity, or high complexity? And this table below shows a correlation. So if someone is a low complexity, we're going to give them this CPT code, which is to show that they're stable and or have uncomplicated characteristics. While moderate, we would give them this code, and this is for evolving clinical presentations with changing characteristics. So maybe they have about, they have about 2, maybe 3, I think, but I think 2 is the magic number. 2 comorbidities, such as, they have diabetes, which depending on how severe their diabetes is and whether it's controlled or not, can definitely affect a session, or can even lead to other signs and symptoms. I'm sure you guys have heard about neuropathy before, and people with diabetes tend to have peripheral neuropathy, and this is where they're like, I have tingling and numbness and I can't feel the bottom of my feet. And it's like, what? You know how awful that must be? Like, imagine when you sit on the toilet for too long and you're like, they're tingling, you're trying to walk and you're like, I can't feel the bottom of my feet. That's basically the same sensation, but they have that constantly. So it's really important for them to look after their feet health, because if they don't look after their feet health, like in a sense that maybe they stepped on a nail and they can't tell because they have lost feeling, and now this nail in their foot that they haven't checked, because who really looks at the bottom of their feet anyway, has turned into an infection. That's just another evolving complication that might actually turn them to a high complexity patient. So yay. Thankfully, how do you call it, people with diabetes who have peripheral neuropathy and or have lost like sensation on the bottom of their feet, there are specific footwear or shoes that they can wear to, how do you say it, to help them out in their life. But definitely do check on the bottom of there for sure. Hi Vicky, hi Galmer, welcome on in, welcome. Hi Parent, hi. Let me go ahead and give you a shout out, Gamer. Welcome. I know, biggest oh no known to mankind. But we basically hinted at high complexity. So high complexity is for unstable and unpredictable characteristics. So bam, there you go. And that's the codes you would give your patients to be like, this is how they're presenting. Here's the medical diagnosis. Here's their treatment. Here's what we did. Yay. Now these are all now you can tell when I started giving up, and these are my what do you call it? My classmates' notes in the lectures. But let's go over this really quick, okay? Francis, are you certain you want to be a doctor instead of a TikTok influencer? Gamer, if I could do the, I don't know what people do anymore on TikTok. if I could do the whip and nay nay, I'm like years late on that, and get 5 billion followers and $5 billion, sure. But you know what, Gamer? I didn't work this hard to just become a TikTok influencer. Again, not shaming people who do that or demeaning their job. I'm just gonna do both. Yeah, why not both? I'll do the whip and nay nay, and then people will be like, whoa, she's a doctor. But not a medical one. Oh my goodness. The latter seems easier? Nah, they both struggle, I'm sure. Manu says that's why they have an anti-flea bit? Oh, French name? No, you're good. To avoid a clog? Yeah, no. It's super duper important to avoid that. Oh my goodness. That's why getting to have the ability to move around is super duper important. I joke around with you cubs from time to time about that, about blood clots, about what do you call it, DVT, the deep vein thrombosis, about, you know, how people how do you call it? I think it's like a bigger fear when people have like the long plane rides. And it's like, yeah, I was sitting on my booty for 8 hours, and no, I didn't do any ankle pumps or stand up to pee. And it's like, or form a blood clot, and that blood clot could go into your lungs, and then you could die or something. That's why it's very important to make sure to stand up and stretch. If you're lazy like me, just chug a bunch of water, okay? So even if you forget to stand up and stretch, your bladder won't forget. It will stand up for you. Unless you're a gamer. I don't recommend that. Eating Tide Pods isn't in anymore, right? Yeah, definitely not in anymore. Definitely very out. But thank you, Nani. Thank you. I appreciate it. And thank you for your hard work in the hospital, because holy heck, inpatient's no joke. Huh? Now you're scared about your next flight to Japan? Gamer, it's fine. Don't worry, just do your little ankle pumps and have fun with your trip. Does Topany turn you into a giant toe? Only one way to find out, gamer. And Weep says, Worldwide Cubs, let's go! Mr. Worldwide over here. Put me with the sunglasses and give me a little bold cap. I could be Pitbull. Anyway, so yeah, CPT codes, am I right? Let's see. Do I have to read this? Let's go over the general concepts. Never heard of ankle pumps? Gamer, I got you. Here's free Topany, but it's not my foot. I hope this is no one's foot, because I definitely didn't draw their legs right, but it's fine. Imagine these are your legs. This is you. I don't know what happened to your torso, but it's fine. These are your legs, right? All you have to do is bring your toes up and bring your toes down. You can even do it while sitting, and that's most likely what you're doing, because I'm also sitting because I'm also at my computer and desk. But you just bring your ankles up and down, and those are your ankle pumps. Ta-da! What on the torso? Where do all the organs go? The only organ you need is your brain, so it's okay. There you go. And that's all. Ta-da! Ankle pumps. So it's very easy when you're in a flight, because let's say you're on the plane. Right, very exaggeration. Like, let's say you're on the plane. And the plane is only apparently 3 rows wide. But the only escape, like, you're on the aisle seat, or no, you're not the aisle seat. You're in the window seat, and you're looking at the beautiful sky. Gosh darn it, this was so expensive for no reason whatsoever. Yeah, and you're stuck here because you don't want to be rude to the other people who are probably just sitting here. Yeah. You could do ankle pumps, and so you could avoid some blood clots, because getting some circulation in your legs is good. Tippa approved. Sorry, let me make it more official. Tippa approved. And then we put some stars or something. Make sure to do your ankle pumps and stand up and stretch and drink water and live a healthy lifestyle for a full life. The more you know. Okay, anyway. Anyway, let's go back. Was that an exercise? It is! Your ankle pumps are your exercises. I'm cracking my ankles as we speak, just doing it, you know? Information uncleared! Ankle pumps turn into leg day! Gamer. Is it worth saving this? Nah, fine. Always at the window seat? Oh, gamer. Last time we went on like a big trip like that, I had sat in the middle because one of my friends really likes the extra room from the aisle seat, and one of them really likes the window seat to look outside. And so I'm like, oh, you know, I flew a lot from New Bearcat City to Bearcat Mountain when I was young. So like the appeal of the window is really nice, because I could just stare out the window, and that could be like my 3-hour flight. But I was just like, oh, well, it's fine. The appeal is not that's worn off, but if you want the window seat because you don't fly as much, I guess you can, you know? You want to hear a family drama story? It involves planes indirectly? Alright, but you have to TLDR it, okay? You can't be like, it all started when you were 5, because then I'd be like, gamer. No bandit nor freckles? 100% not Tippa. Oh, you're so true. But it was me at my strongest form. My strongest form would become a TikTok influencer about telling you about your leg health. Or sorry, your blood circulation health. Anyway, alright. I have 15 pages out of 41 and it's 2 o'clock. Alright, Cubs. So, CPT codes are very important because actually every medical professional uses some type of coding or CPT codes. But CPT codes are some are more specific for different how do you say it? Healthcare professionals. So we could talk about which discipline can bill for which code, and we can use one that has a strong overlap with each other. Oh my gosh. We could talk about physical therapists and we could talk about occupational therapists, and it's the idea that there is an extreme overlap. Both can do therapeutic exercises and they could both bill for the same code. Gosh, I'm digesting my oatmeal. They could both do neuromuscular re-education, but occupational therapists cannot do gait training. I mean, they could, but they don't do, how do you call it? They shouldn't. They could, but they shouldn't. Occupational therapists don't work on functional activities like physical therapists do, and physical therapists are trained on the gait cycle to heck and back, and you cubs are well aware of that they're the ones who are specialized in that, and that is the only discipline that could bill for that. Let's skip that one because I don't want to read that one. But for self-care home management, physical therapists don't work on occupations or activities of daily living. They work on more broader things like walking or climbing stairs or reaching, etc. When you're trying to work on activities like, hey, I am having troubles with my I'm having trouble using my hands and I can't use a button-up shirt anymore, and I'm a business lady and I have all these formal occasions where I need to use a button-up shirt. It's like, oh, well, physical therapists don't work on that, but OTs or occupational therapists do. So having self-care home management training, direct one-on-one, blah, 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 that can be built by an occupational therapist. But again, it's just knowing the difference of what each specialty does. Alright. That's not important. That's not important. That's not important. 8-minute rule. Okay, that's important. Alright, Cubs, we'll take a little baby break after I catch up with chat, and then we'll talk about this heck of a system. This 8-minute rule had me like pulling my hair out yesterday. I was like, I don't get it! Anyway. Parents says TLDR. My aunt thinks she's a genius. She combined flying anxiety medications, oh god, with copious amounts of alcohol for my grandparents' marriage anniversary family dinner at an expensive restaurant. Fun ensued? Brother, I would never mix any alcohol with any medication. That's horrifying. Oh my god. What? I know there's some people who have severe anxiety like that, but not like that. Shouldn't do it like that. You pick one or the other. You pick or choose your battles. And brother, both of those are not a battle that I would like to be facing. Oh my goodness. Kinesiotherapy equates to physical rehab? Ergonomics is for the arms, upper limbs? Yeah. Almost right, similar terms, gamer. She fell and sprained her ankle. The police was called? Why did they call the police? What? Oh my goodness. But anyway, gamers, let me politely BRB. I'm standing up and stretching because gamers, we are page 17 out of 41. So we're making some good progress, but hopefully we'll be at least at the halfway point by 3 p.m. So you know. She started screaming she was inconsolable for a marriage anniversary? Your aunt is wild. Ankle sued her for damages? Brother, I would too. My ankle gains a consciousness? Okay. Anyway. Oh. Let's go, gamers. I will politely BRB now, so I'll see you guys in a little bit. Let's stand up and stretch and also avoid those DVTs, okay? Okay. BRB!
かすかに響き渡る教会のチャイム、祈りを捧げ今日を裏切る。暗い森の中をさまよって暗絶の壁な残月になるの。透明な嵐に待ち出す甘い淡い蜂蜜でもっとベトベトにしたお願い。いい子になるから私を承認して。風に舞う絵本のページが影になる記憶を揺らすの。ずーっとあの場所で待ってるから。空っぽの世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて。花びらがゆっくりと二人を包むよ星の夜に。ねえね迷い込んでしまった出口のない迷路、ぼんやり口ずさむ同じ聖書、秘密の呪文ちぎるようにオルゴールが静かに歌うの。透明な嵐に待ち出すに弱く荒く噛んでもっとぐちゃぐちゃになったらお願い。いい子になるから私を承認して。絡め合った恍惚な時が重ね合ったあの日を照らすの。ずーっと私はここにいるから曖昧な未来であって何も怖くないよ。差し出された手に触れて高まった糸が優しくほどけた。不条理な傷つって舐めてあげるから星の夜に。ねえあの森で待ってるからあの場所で待ってるからあの場所で待ってるから空っぽの世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて。花びらがゆっくりと二人を包むよ星の夜に。ねえねえねえ。
Sorry, Erika. I'm so sorry. How do you call it? I almost fell asleep. Babies was being so cute, and I was so happy, and I was just like, oh my goodness. She's so cute. I woke her, I'm hugging her, and I thought I was being like a menace to her, but then she started purring, and I'm like, baby. And then she laid on my lap, and I laid back with her, and I was like, and then she didn't move, and I'm like, I could fall asleep just like this. I hope you guys had a super good break, okay? Let me see. Oh. let's get back into it, okay? Oh wait, but let me make sure I didn't miss anything. I don't know if you have to go. I'm so sorry, gamer. I hope you had a good one. Thank you for stopping by. Thank you, thank you, thank you, thank you, thank you. Alright, let me go ahead and do this really quick. Okay, I'm done. Alright, let's go ahead and get back into it. So, let's talk about the 8-minute rule. So, the 8-minute rule was literally having me pull my hair out because I was like, I don't get it! I already hate numbers! What do you mean the 8-minute rule doesn't like break into a, how do you call it? Oh my gosh, how do you say it? 8 intervals, like 8, 16, 24. Why is it 8, 23, 38, 53? Who made these numbers up and who do I have to kick? Like, what's happening? It turns out that this is actually divided into 15 minutes. So it's 8 plus 15 minutes. So 8 plus 15 is 23. 23 plus 15 is 38. 38 plus 15 is 53. I didn't get that. I didn't get that for the longest time. So what is the deal with the 8-minute rule? So we talked about previously before the BRB, we talked about ICD codes, which again is going to be specifying, sure, diseases and disorders, whatnot, while the CPT codes are going to help with our treatment and what? Our treatment and diagnosis, right? Yeah, treatment and services provided. While ICD is going to be describing a disease or injury, CPT is going to describe a service and procedure, and ICD is going to stand for International Classification of Diseases, while CPT is current procedural terminology. Disease, service, disease, service, disease, service. Okay, anyway. So for the 8-minute rule, what's going to happen is that, yeah, okay, you do gait training and here's the CPT code right here, and you're gonna bill for 1 unit, and 1 unit is saying that, hey, I did gait training for 15 minutes. Great, cool. Well, life decided to be really hard and be like, okay, but how do we bill you for that? How do we charge you? So they decided to do this thing called an 8-minute rule. So what's going to happen is that you're gonna total up your treatment time. And we'll do some examples later. This is the stuff that we're going to work together with because gosh darn it. So, you're going to put the treatment time together. You're going to subtract the total events or service-based minutes, which we'll talk about a little bit later. I think those are like more like group workouts. And then from there, you're going to calculate the number of time-based units. What does that mean? Great question. We're going to work through it together. But yeah, less than 8 minutes is free, and basically you don't get paid for that. So whatever you're doing for less than 8 minutes, heck you. That actually explains why when I was a tech, why when we used to do a ultrasound, they said the minimum had to be 8 minutes. Not 10 minutes, 8 minutes. It's like, oh, I now understand why. So we're gonna go over examples so we can get through it together. But let me see something really quick. For CPT, you have time-based codes, so reimbursed on time, and then event or service-based codes where you're reimbursed on the service or the event. So event or service doesn't have to just be group therapy, it could be evaluation. While time-based is like, oh, we did gait training for XYZ, and we did therapeutic exercises such as improving strength in right upper extremity for 15 minutes. These are all time-based. Okay, let's get into the examples. I didn't do all the examples, so we can do them together. Yay! Point left, point right emoji. So for the 8-minute rule, I think it's very important if maybe we keep this bad boy with us right here, and we'll just keep it. So, oops. We'll just keep it here, okay? Alright, so let's say, for example, we are doing 7 minutes of therapeutic activity. And it's like, oh, that's not the 8-minute rule. Shouldn't you do 8 as a minimum? Well, in this case, it doesn't necessarily matter because we're going to total them up, and from there, we're going to subtract the amount of service-based interactions, like if we did an evaluation with them. But this looks like a normal session that we would do with a patient. So they did 7 minutes of therapeutic activity, which they put the CPT code of 97530, which is a CPT code for therapeutic activity. And then they did neuromuscular re-education for 97112. So they did 7 minutes of that, and they did 7 minutes of gait training. So all in total, they did all these activities, but it only totaled up to 21 minutes. These are all time-based. There's no events, so there's nothing to subtract from. So 21 minutes is our ending number. So how many units can we bill for? So then we refer to our little guide right here about the 8-minute rule, and we find out that, hey, with the 21 minutes, it turns out we can only bill for 1 unit, because it falls within this first one of the 8 to 22 minutes. So we could only bill 1 unit, but we did gait training, we did neuromuscular re-education, and we did therapeutic activities. So which one do we bill for? And apparently, you're still going to document that you did all this, but for billing purposes, what you're going to choose is the one that's going to be the most clinically relevant to your treatment. So we'd probably be like, oh, gait training was probably the most important thing. We did all these neuromuscular re-education, therapeutic activities to work on gait training. We're gonna bill for gait training. Sure. It's weird, but sure. Now let's move to another example, and hopefully we build our foundation for this, okay? So for example 2, we did 21 minutes of therapeutic activity, and then we did 19 minutes of group therapy. Group therapy is going to be, though it seems like it's time-based because we did it for 19 minutes, group therapy with the asterisk right here is going to indicate that it's an event or service-based code. So from the 40 minutes, because that's totaling up both our group therapy and our therapeutic activity, from the 40 minutes, we're going to subtract our, again, event or service-based code. So we're subtracting 19 minutes. And because we are subtracting 19 minutes from 40 minutes, we're gonna end up with we're only gonna end up in this first category right here, right? Because I'm doing the math right? What's 40 divided by 19? Yeah, 40 divided by 19, you're gonna end up with 21 minutes of total billable service. And so you're only able to bill for 1 unit, and that 1 unit is going to be... Wait, never mind. Let me actually read this. Alright. Alright. So when we subtracted 19, we ended up getting 21, correct? And so the rest of the remaining time from that 19, which is with the group service, is 21 minutes. So for this example, we are able to bill for 2 units, but that might not be because it's time-based. It's because one is a time code and one is a event and service code, and those are 2 separate units in itself. So these rules don't matter? Question mark. I'll ask my classmates about it. Oh. But that's what I'm getting at. Maybe, I hope. Gosh darn it. Alright. So here are the other examples. Hold on. We'll put this in a little box. It won't be the prettiest box, but it's fine. So here. And then this is example 3. Okay, I feel like I'm missing words here. I was. Oh my goodness gracious, great balls of everything that's fire. Alright. So example number 3. So let's shorten this out. So they did 24 minutes of, oh my gosh, minutes? of neuromuscular re-education, and then they did 23 minutes of therapeutic exercise. Okay, so we know the total is going to be 47 minutes, and because we're using our handy dandy part right up here, we know that 47 minutes falls into 3 units. 3 units. So we're allowed to bill for 3, even though individually they're both enough to reach for the 2-unit threshold. Oh wait, what's happening? Oh no, okay. Okay, so it's saying we only did 2 things, but because of the amount of time that we spent, we're able to bill for 3 units. So we're allowed to build 3 units even though individually they were both enough to reach the 2-unit threshold. Okay, because it's talking about total time versus individual time. So because of this, we're going to build 2 units to neuromuscular re-education because that one had more minutes spent on it, and 1 unit to Therex because the total treatment time constrains the number of units we could build. Okay. Dumb, stupid, but it makes sense. So to regurgitate really quick for my dumb brain, every time you do something like this with billing, you have to add the total amount of time and then reference this chart up here. So again, we only did 2 interventions and it totaled up for 47 minutes. For the 47 minutes, it falls into 3 units. But we only did 2 things, but we could bill for 3 units, so we have to pull 3 units out of our booty, I guess. But how we do the math is that because we spend more time in neuromuscular re-education, we could build 2 units of this and 1 unit of this. That's all I got, Chief. Okay, moving on to the next example. How many examples are there? 5? Oh, gamer. Okay, that's fine. Smile emoji. So let's minimize this and then we'll work together here. Okay, so for example 4, we have 20 minutes of neuro and then 20 minutes with Therex, and then so that means we have a total of 40 minutes. Let's see, can I do this again without reading it? Okay, so if we have 40 minutes, that means that we could bill for 3 units. But oh no, the times are the same because it's 20 minutes of each, so I just picked my favorite one. Oh no, or do I lie? Okay, we'll have to read this one. So this translates to 3 units, but because we spend exactly the same amount of time on each one, we can either bill for 2 units of neuro and 1 of Therex, or 1 of Therex and 2 of neuro. Either way, it would be correct. Either way, you would go with the one most clinically relevant. Your facility biller will tell you to bill neuro because that's the one that pays most. So yeah, most expensive, baby! Okay, interesting. Alright, and we'll do the last one. Apparently there's a example 6, but it's not actually written here, so we'll keep this one out here then. So let's go. We have 33 minutes of therapeutic exercise. Then we have 7 minutes of... Oh, I took off my glasses by accident. Heck. Sorry. That's my bad for having my keybinds. Whoops. Anyway. Then we have that. Then we have this. And then we have total equals 40 minutes. Which we... Okay. TLDR? No, thank you. Well, yeah, actually, yeah, thank you, actually. Yeah. Because you add 15 from each one. So yeah, 8 would be 1, 23 would be 2. Yeah, basically TLDR. And if they're the same, you bill for what is more expensive. And if they're not the same, then you would have more of the one that has the most time to it dies. Imagine apologizing for keybinds? Brother. No. Every time I type a number, I'm afraid. Surprisingly, the numpad stuff doesn't work. So I should probably use my numpads more, but I didn't grow up with that, so... Anyway. Okay. Bring this back. our last example, and then we can move on from this heck hole. But now that I understand it, I'm like, oh, it makes so much more sense than it did yesterday because I didn't want to look at it yesterday. All right, number 5, let's go. So for example 5, 33 minutes of therapeutic exercise, 7 minutes of manual therapy, so it's 40 minutes. And if it's 40 minutes, it falls within 3 units. So would you not charge for 2 therapeutic and 1 manual? What does this say? Oh, yes. Okay, so for this example, it'd be correct to build 2 rounds of therapeutic exercise and 1 unit of manual therapy. It's all making sense! Okay, so let's do number 6 together then. Sorry, I lied to you, Cubs, because it's actually here. It just wasn't here in the way that I wanted it to be. Alright, so... oh, they have so many things though. Okay, so they have 18 minutes of Therax, 13 manual, 10 gait, 8 ultrasound. And so they say that the total is 49 minutes. And we know 49 minutes goes for 3 units. But we did 4 things, so it's like, okay, where do we put the 4th one? Or do we not count ultrasound? So let's see. So you're gonna give 1 to Therax, 1 to manual, and 1 to gait, because those were the codes that we spend the most amount of time on. We're gonna document for all 4, but the total treatment time constrains to the number of units you're allowed to bill, and you're only allowed to bill 3. Okay, mic drop. I'm done with this. I'm done with numbers. I get it. All right, document all, but you can only bill for 3. Bill for the ones that you spend the most time on. That is the TLDR and what I spent probably the last 20 minutes on. Thank you, Cubs, for your patience and understanding. We're gonna do so good on this midterm quiz. All right, modifiers. I didn't have anything in particular. I know my classmate did, but he highlighted in red, so I was a little confused because there was another modifier down here, but I'll try to explain it. Maybe I won't explain it. Never mind, I lied. Sorry, Cubs. I'm gonna find, yes, here. Okay. So, when it comes to coding, for goodness knows whatever reason, National Correct Coding Initiative CCI edits. Medicare National Correct Coding Initiative, aka CCI, was implemented to promote national correct coding methodologies and to control improper coding leading to inaccurate payments. Okay. Ugh. How to use column 1 and column 2 tables. It's gonna make sense when I look at that table, but it's just weird. Column 2 code is often a component of a more comprehensive column 1 code. PTP code. Okay. So for whatever reason, there's things called modifiers, and there's like 3 different aspects of how to use them. We would be using them in this example for CCI coding and billing and whatever else. But if there's a modifier, so you have a CPT code, you know, we were talking about gait training, ultrasound, neuromuscular re-education, etc. If there's a parentheses and there's a 0 there, that means we're not allowed to bill it. But if there's a 1 besides it, like gait training in the parentheses 1, we are allowed to bill it. I'm gonna read everything and hopefully it all makes sense to me. Alright. So if there's a 0, you're not allowed to bill it. Under no circumstances, Medicaid is going to pay for both procedures no matter what you document. But if there's a 1, you could be reimbursed for both codes. In fact, you're doing it correctly and you also supply the appropriate modifier that you documented. Okay. So it would look like something like this. Now don't get me wrong. I must not know what these codes are for. And unfortunately, I don't remember if they said there was going to be a reference or not. It probably doesn't like necessarily matter if whether you know it or not. It's the idea of whether you know the modifiers right besides it. But I'm able to bill for both this and this. I'm able to bill for whatever's in column 1 and column 2. I would not be able to bill for both column 1 and column 2 if column 2 had a 0 in the parentheses. Like if this had a 0 but this had a 1, I'd only be able to bill for this one in column 1 and this one in column 2 because this one would have a 0, and again, Medicaid wouldn't pay for it, so why even work on it, you know? The thing that's interesting that I don't think they really add on to this, unfortunately, is there's 4 new modifiers that they added into billing. I'm gonna cry. But this one's really interesting. So this one is that we'll explain it in order because there's no way of me like hopping around this. So when you're billing and you put XE is for a separate encounter. So if you had a column 1 and column 2 code that are billed for the same patient, but they're the separate encounter, then use the modifier XE. So let's say we did gait training in 1 and there's a variation in 2, but these were 2 separate encounters, but they're like within the same categories or they share column 1, column 2, you would use this modifier of XE. I don't think XS or XU applies for us, hence the highlight, but XP is for a separate practitioner. So if a separate practitioner did something very similar, let's say OT, but they're a different person, like, oh, I'm PT and they're OT, then you would use XP. So the billing can look at it and be like, hey, you guys are not just redundant, you both specialize in your own different ways, but you are both doing therapeutic activity. Because you use this XP modifier to show that difference, or to differentiate between the two, will approve the billing and you'll get paid for what you did. Yay. Gosh, billing, so healthcare is so everything, but it's fine, because guess what, Cubs, you're on page 25 out of 43, and we're gonna get into something that's a little bit more not as convoluted or convoluted. This is actually note-taking. So billing sucks booty cheeks. Notes, they actually also suck booty cheeks, but there's like different formattings that you can use, and we'll talk about them in just a moment. The formatting though is hecked, so I do want to apologize in advance for that, but it truly is what it is, you know? In this economy with this time limit, yeah. So it's a little okay, I'm gonna stop being a baby. All right, so when you're making notes for patients, obviously it kind of helps to have an idea of what you did with the patient. Not only is this important for insurance, but maybe sometimes you're not taking care of the same patient. Maybe your friend is taking over, or your coworker friend, or I guess it could be your actual friend, who knows. But maybe someone else is going to take care of them, but they want to know, hey, what did you do with this patient? And of course, yeah, you could probably ask the patient, hey, what did this other therapist do with you the other day? But they'll probably be like, yeah, I don't know. So it's important to have some type of documentation to know the general progress of this person. These notes can be daily notes, or it can be evaluations, but most of the time you'll see these SOAP notes for daily use. There's different type of note formats we can use. We could do a narrative format, which you see right here, which is basically telling a story. We could do this one. We can kind of run through the narrative format. It has their name, the date of service, the time, the reason for the referral, and this is basically a not an evaluation. You're always evaluating. It's not an initial evaluation. This is just evaluating, be like, oh, how's this person from before? But it's like, patient reports pain. Increased pain with this and this and this. We took some measurements. This is their measurements. The treatment today consisted of 1, 2, 3, 4 different treatments. Patient was able to do this. Patient notes decrease in pain last time. Patient this, patient that. Next few sessions are going to be focused on progressing active range of motion overhead, initiating, strengthening, eccentric exercise. It's narration. It's like a big block of words. It is basically a commentary of everything that had happened within that 45-minute session that you had with that patient. So that's a format you can use that's acceptable. You can also do another format called POMR. It is called Problem Oriented Medical Record, where pretty much you describe the patient's problem in a list. There's a subjective and objective data, subjective being that the patient reports it, objective being that you had measured it, maybe something like their active range of motion, like maybe something with their shoulder. The overall impression you had from that evaluation, whether they're getting better, worse, or the same. The treatment that was provided, and the plan for each problem. Basically, this is the narration form, but this is much simpler. This is much cleaner to look at. The only problem is that this, you would have to write like a SOAP note, which we're going to talk about in a little bit, for each problem list. So same thing with the narrative format, but you have the patient's name, your date of service, their physician, their chart number, their reason for the referral, and here's their problem list. Shoulder pain, decreased shoulder active range of motion, muscle weakness, painful recreational activities, work-related tasks, ADLs, etc. You get your subjective information, such as the patient's reporting 6 out of 10 pain. You get your objective information, the measurements of their motion. Okay, this is how much they could do in shoulder flexion, external rotation, etc. And the treatment consisted of 1, 2, 3, continue. This example only addresses problem number 1. You would have to write notes to address all problems. So again, this is a lot already, but this is only for 1. So you do the same thing again and write subjective information about the decreased shoulder active range of motion. You would write something, and an example would be like, oh, patient reports, because patient reporting is subjective information, saying, owie, owie, shoulder hurts. I don't feel like I could bring it up overhead to grab this can of beans on the top shelf of my pantry. Whoever puts cans of beans on the top shelf of their pantry is the Lulu, but that is something they would probably report, and then the objective measures would be like, hey, we did active range of motion and we got these measurements. Muscle weakness, they will again tell their story, and then objective measurements, maybe we'll do a manual muscle test to assess their strength. Like, yeah, they are 3 out of 5 when they should be like a 5 out of 5, you know? So it's cute, but it's a lot of wording going back and forth, back and forth. The most popular note format that we use as therapists, though, let me see. Oh my goodness. Sorry, the formatting here? Crazy. But yeah, a very popular format that we use as therapists is actually called the SOAP note. So this is the subjective, objective, assessment, and plan. SOAP note! And it's basically the same thing that you saw here. The only difference is that it's more focused on the A and the P, the assessment and plan going forward. You can use SOAP note with coding, so we can use it with the CPT codes that we had saw earlier, or you can use it without the CPT codes. Now, I recommend you use the CPT codes because it's 2 birds with 1 stone. 1, you have an active list of what you're doing, and 2, you could show it to the people who are going to pay you, the insurance, to be like, hey, I was doing X, Y, and Z according to these codes. Please reimburse me, basically. And they'll be like, okay, you were doing these things. Wow, amazing. And yeah, that's basically it. We can read through the SOAP note though, but we'll focus on the A and P, okay? Parent says patients is being overdramatic, shoulders still slightly attached to body, blood loss not that bad, can wait in ER for 2 hours. That's basically my plan. Oh my goodness. Or assessment and plan, basically. You just summed it up. That's so nice. But yeah. Subjective again. Patient reports this. Objective, we measured stuff. Now the assessment is that the patient notes decrease in pain since last week. We noticed that their scapular humeral rhythm is improving, which I'm not gonna get into that, Cups. I'm so sorry. Patient still reports difficulty with sleeping. Protective extensions. Plan. Next few sessions focusing, progressing, overhead range of motion, initiated strength. I'm so sorry, Cups. I'm getting tired. I'm getting tired. It's the idea again of that we had assessed them throughout this session, and they had made these additional notes while doing these things. But we had assessed this because they're like, oh, I'm having trouble with this, but oh, we did this, and there's been some noted improvement. Hey, the plan is that we're going to continue on XYZ, and so when the next therapist looks at this, that may not be you, or it could be you, and it's a nice refresher. It'll be like, oh, I do have to work on these things, and this is what we're going to work on specifically that I'm going to add into their therapeutic exercise for me to bill. Bam. The only unfortunate poo-poo pee-pee thing about note-taking is that Medicare minimum requirements meets all of these in order for it to be approved. If not, again, your note is going to be audited and it's going to be like, hey, you don't have enough information, we're not going to pay you. What? So you need data treatment, objective measures, so again, the measurements to show that they're improving, because again, yes, it's nice if the patient reports subject information saying like, wow, Dr. Tippa, my pain went from 8 out of 10 to like 2 out of 10. You're doing so great. But those numbers can highly vary from day to day. They're not necessarily reliable, which is why you need these objective measurements. You need to always provide education. There's a funny hacked up story. I was like, no way did this guy just do this, but that's too long of a story to like go into. But it's the idea of like, hey, I educated my patient to make sure that they do this with their arm instead of this. You know, very simple things like that. It doesn't have to be a whole spiel or have to be a 3.5-hour study session to be like, yeah, your arm is hacked up because of this. Skill documentation by CPT code. So again, CPT code going back to the SOAP note, but we could add coding. Total time billed for each time and untime code. So that's going back to the 8-minute rule that we just talked about and our experts. A legible signature. And then sometimes you'll need to add documentation by exception. So patient self-reports can be, again, that subjective information from the SOAP note if you so choose that format. Adverse reactions to interventions. Maybe they went on some new medication, you were doing the same old stuff, but then they are reporting a lot of fatigue. That's something that you want to put into your note. Communication or consultation with other providers. Maybe you notice something on their back. Maybe you notice an uneven, mole on their back. And it's like, hey, do you know about this? And the guy is like, no, I didn't know about this because I can't look there. And no one has brought it up to me otherwise. Then maybe you want to make a referral to a dermatologist. Equipment provided. Maybe you provided them with Therex bands. So like little elastic bands to maybe do some of their at-home exercise. Or any significant changes in clinical status is going to be super important while noting. Hi, Cloudy. Hi. We just give that to admin, brother. I wish. This literally has me at like the throat being like, if you don't do this, you're not gonna get reimbursed and you're gonna get in trouble and you're gonna get audited and gosh darn it. I'm like, please. Exactly. It's like, crap. It's like, do this right the first time or don't do it right at all. And it's like, what? Huh? Anyway. But welcome, gamer. I hope I'm almost done. No, okay. We'll talk about the SOAP note in more detail like right now. Let me take a little hydrate break. And also, guess who's here? Cups would never believe it. Hold on. Let me hold on. Hey, baby, please. Let me just put her right here. I'm gonna have to fix the camera. Sorry, I'm on another screen right now. Ta-dang! Baby, please, and that's my hand. Sorry, close that. She's so beautiful. She's so ippy. Live piece reaction. She's so beautiful. Look at her in her little paws. Oh my goodness. Live Eeper cam. So ippy. Again, I'm telling you. I would have been sleeping right now. I could have been nappy on the sofa with baby peas. She's just so comfy. Must pat. She's so eepy. Her eyes are closed. She's not even humoring me. She's in deep sleep right now. I can't do it. What's her cat's looking like a leg of turkey? Brother, don't touch her leggy. It looks okay. She's so eep. Now don't get me wrong, I don't think it's comfortable to sleep that way. But baby Peace can do baby Peace. Peace is the best turkey. Nom 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 nom. Don't eat her. Just like turkeys, they won't have much flavor. Anyway, gamers. Ooh. Let's get through these notes. So that we can have some freedom. Because I think that's it, right? Hold on. Okay, this is... Oh, thank goodness. Okay, and that... okay, whatever. Alright, so we'll explain SOAP notes. We'll talk about some of the modifications again, because they're down here. And we'll wrap up with some silly business about how to be not professional. Yes, how not to be not professional. And we'll move on to the Quizlets. Or maybe I'll wrap up stream, take a little quick walk, and then run through the Quizlets and be like, ugh, gosh darn it. But part of me is like, how will I know I do all the Quizlets if I'm not held accountable? Oh no! We'll see where it goes. Anyway, let's talk about SOAP notes. So again, SOAP is a subjective, objective assessment and plan. So what does that even mean again? We'll break it down. So subjective again is what the patient says or reports about the problem. Again, reports that they're icy, reports that they were sore after last treatment, reports that they've been completing their home exercise program and that they're noticing more range of motion and less pain. Great. This is again, subjective information is everything that your patient reports about their problems and or interventions. You can kind of sum it up of saying like, this is what has happened since last time. So it's like, patient, tell me how you're feeling since Monday. It's Wednesday now. Are you feeling good? You're feeling bad? And it could be like, yeah, my pain right now is 5 out of 10. I'm feeling okay. Blah, 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 blah. Now, objective, this is how your patient's performing with the activities that they're doing for PT. And this again could be related with the codes. So here's some examples here. Again, objective is objectively how they perform during treatment. So we have range of motion right here, 120 degrees of shoulder flexion, complains of 4 out of 10 pain past 90 degrees. During their intervention, they had 2 episodes of loss of balance, and this was they were losing balance to their left side during dynamic standing exercises. And that, I don't know what this means. I don't know what /C is. Ooh. But yeah, stuff like that. But always remember, unless it can be billed, the patient's clearly imagining it. That's so true. No, but I can't do that. I'll be kicked out of my own profession. I didn't even start yet. But yeah, for objective as well, they also crammed in education here. Education, again, is just being able to show a patient something and doing that callback method of like, hey, can you tell me what we did or can you replicate that, you know? And so it's like, who was educated? What are they educated on? What methods was the information delivered? Like, this can be super vital, especially if maybe they're using a new assistive device. So hey, they never used a cane before. Hey, let's teach them how to use the cane. Hey, can you recall back what hand I said to use the cane in? And how are we gonna walk with what first? Are we gonna use the assistive device first? Are we gonna use your leg? What leg are we using first? Da 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 da. So education is super important and can be easily documented to be like, look, I'm doing good. And they're doing good because I taught them how to do XYZ. Yay! Alright, assessment. Therapist analysis of patient's performance. Why the patient performed the way they did. So we can do weight acceptance improved during gait, secondary to decrease in lift hip pain, bed mobility improved static balance, and this is why it was improved because of XYZ. It's basically why the performance performed the way they did. That they hesitate to accept weight? Are they having problems due to not being able to detect their limits of stability? Are they not able to maintain that line orientation? So it's really important to kind of assess what they're doing and have that solid assessment to be like, hey, these are some things I've noted, maybe some aspects of weaknesses. How are we going to apply this then to the plan to improve these things that I've noticed, if there's weakness to be noted? And so plan of care, basically, you don't want to say continue with plan of care because what does that mean for the person who's not you? So plan of care is how the treatment will proceed to reach intended goals. So the next few treatments can include overhead reaching outside a base of support. Maybe they're having some issues reaching beyond that base of support. They're losing their balance. We're going to work on some activities to help train that. Or maybe we're going to progress them on unstable surfaces. Okay, we're going to work on marching on an uneven surface like a foam pad or something like that. Or we're going to contact the durable medical equipment guy to schedule a wheelchair custom assessment to make sure that, hey, if this person's going to be using a wheelchair for a long time or maybe even for life, how can we get them set up with the best wheelchair possible that's going to fit their needs, and how are we going to teach them how to use that and how to get moving and grooving with some of their things in their activity lives, like how are they going to get around the house, or how are they going to start bathing with a wheelchair, etc., etc. And this is repeats. These are the CPT codes specifically for gait, neuro re-education, therapeutic exercises, manual therapy. Ba 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 ba. This is the modifiers. These are the notes. These are the columns again. Let me read this really quick. But hi, Reptile. Hi, Gamer. Welcome on in. Welcome. Hi, Tipa. Hi, Baby Bees. Hi, Rip. Hello, Gamer. Welcome. We're almost done with this thing. Maybe I will wrap it up after this so I could do the Quizlets on my own and eat my instant ramen. I'll eat instant ramen while going through the Quizlets and be like, alright, 7 o'clock cannot come soon enough. The worst part is that hopefully by the time I get to finish everything, maybe it'll be like 5 or 6. Heard that, everyone? Tippa's tired of us. No, I'm not tired of you, Cubs. I'm just tired of like looking at notes. Again, I can't look at notes that are just paragraphs. If they're not bullet pointed, my brain just like glazes over them and I'm just like, what? Why? What's going on? What? But yeah, I think I'll read that in a little bit later. We'll talk about like very baby easy stuff, okay? So let's talk about the generic inabilities. So not only do we have to respect our patients while we're doing experiences working with patients, while we're still training to be baby therapists, we're going to be working under someone called a CI. And our CI are our clinical instructors. And basically what's going to happen is that it's really important to still remain professional with them. They put this really heavy, weird focus on generic inabilities. So you know how to be a good student and all that, but what are some things that you should watch out for? You should be careful about your attitude. You should be careful about your lack of interest. You should be careful about your poor communication. And just be careful about general unprofessional behaviors. And then it breaks it down. So it's really like, what? What? Yeah, let's break it down, Cub smiley emoji. So attitude. So if you're arrogant, abrasive, authoritative, disrespectful, demonstrate that their affiliation was a waste of time or overconfident, those are all bad things. Boo. Boo, 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 boo. It's like going to your mentor and being like, yeah, you hecking suck. And this was a waste of time. I don't even want to be in this profession. It's like, brother, you're wasting everyone's time. Your lack of interest. So if you're unprepared, like sometimes what happens is that when you work with a CI, they might give you little mini assignments or mini work to be like, hey, come back with me tomorrow after you do this assignment. And it's like, if you don't follow through with that, then you're missing on a really golden like learning opportunity that your CI had set up for you. And that just shows again more of your lack of interest. Maybe you lack initiative, and maybe you require a lot of spoon feeding the information. Like you're like, what's a shoulder? And it's like, oh brother, what do you mean? That's definitely something you could easily look up. Poor communication, just not being able to communicate needs, or having inappropriate language, gestures, or conversations. Maybe you're arguing, maybe you're complaining, maybe you're having tasteless jokings, and maybe you're just flat out not responsive to the patient. The patient's like, yeah, I need help. And they're like, you need help? I need help. Something like stupid like that. And then general unprofessional behavior. So maybe you dress inappropriately. Ooh, you got spaghetti straps or something. Poor time management. So maybe you're constantly late to your sessions. Being dishonest, unable to maintain confidentiality with your patient, which is super important. So it kind of sucked to be like, yeah, I took a picture of this patient's knee. Look at their scarring. Isn't it so ugly? Yeah, that's John Smith from the 3 p.m. session. Like, brother, what the heck? Being immature, maybe a lack of balance between personal and professional life, crying, lack of confidence. Oh my goodness. And really just does not take responsibility for their actions. You don't follow the policy or procedures, and you change treatment plans without permission. Because remember, when you're practicing with CI, at that point, yeah, you are pretty much a practicing PT, but you're not licensed. You can't just change up treatment all willy-nilly just because you feel like it. It's important to have that ability to communicate with the person who has the initial treatment. And yeah, you just can't go changing that. Oh my goodness. But yeah. And that is it. Yay. Yay. Someone's in my document. Yay. And that is everything I apparently need to know by the time of my midterm. So as you see, they're all kind of conceptual. Minus a little bit of math for the 8-minute roll stuff, you know? But yeah, I'll make sure to have enough energy. I can humor you cubs and look at the Quizlets. I think there's one Quizlet. Let me see. Hold on. I can hear the neurons. They're like little bees buzzing. Buzz, 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 buzz. Yeah, I can do this. Let me see. Yay! So this Quizlet's only 88 questions. Then I could do the other one that's 157 later. This has multiple choices too. Oh, you're thinking like Pop Rocks? Oh, my bad. Parent says, Tippa, before I leave, I want to know something fun. I had my plasma/blood donation scar be mistaken for drug usage one time before. I'm sorry, gamer. I hope that got resolved relatively fast. Smile emoji. Wow, that scar is so gnarly. Hang on, I gotta post it to my Instagram. It's really important to show patients, like, again, let's use the back mole example that looked abnormal. It's important that you don't take that picture with your own phone, or if you do, you show to the patient that you deleted it immediately. Because again, you don't want to ruin that sense of trust. Again, we're going back full circle to that respect mnemonic. Ooh, respect, and the T is the trust, and you'll break their trust if you start posting stuff on social media. But yeah, sorry parent, if you have to go, absolutely no hecking worries. Thank you so much for joining me and all that jazz. But yeah, let's do some of these Quizlets together, okay? Because one, it holds me accountable that I did it, and two, it's not 4 o'clock quite yet. By the time it hits 4 though. Oh, actually, you know, because if I walk too soon, maybe I'll run into too many people. So 4:30? Yeah. It'll be the perfect time. Actually, Cubs, I didn't get to tell you my story from yesterday. I just felt so bad because I was walking around the park. And, you know how I'm like, oh, I don't really want to run into anyone? Well, I did my occasional nods and be like, oh, good afternoon. Oh. But I felt so bad because I went like an unexpected path because I didn't want to run into this other person going the opposite direction. But I ended up being behind this one person walking their dog. And though we had split off, our paths had met again. And I felt so bad because I'm like, I wonder if this guy thinks I'm following him. And then we walked into the same community and I'm like, I'm sorry. I'm sorry. Again, I probably look like the least intimidating bearcat ever, but it's the idea of like, why is this girl following me? I felt so bad. And then they kept going further in the community and I was like, I don't know how to tell them I live here. But thankfully we split off again. I was like, oh gosh darn it. Sippa walked them all the way to the front door. I was so scared. I'm like, maybe this is my neighbor and I just never knew. But I was like, what? I'm so sorry. I must have been so uncomfortable. They had a dog, so I'm sure they were fine. But like, it's like, oh, I'm so sorry. I just want to enjoy this walk, but I'm here ruining it. I'm ruining the vibes. And yeah, cat, this is my baby Peace, who I can pet now. Hey, baby. I love you. I love you. I love you. You're so easy. Your turkey leg. I love you. Alright. Sure they didn't mind? Yeah, but I felt so bad. Anyway, gamers. One sip of water. Let's get through these 88 Quizlets, okay? So, this one I'm gonna cheat on because I did look at this. Any idea why you got busy? Oh, yeah. I think I slept weird. To be completely fair and honest, when I slept on the couch. Oh. Sorry. When I slept on the couch, right? My couch is cute and it's green. And it looks like this. It's very small. I think I just had my head completely turned one way. Hold on. I was completely like I think because I had my head turned for such a weird, uncomfortable angle, but the rest of my body was like this still. Sorry, this is me. I think just having that head turn was just the most unfortunate thing, and I think this is what they call like what? How do they say it? Like a creak? Maybe it's double E. I don't know. I don't know. E? I don't know. A creak in your neck? And I don't know, but it was so awful because when I had got up, because remember, I took this afternoon nap and I think it was 12:25 p.m. and I'm like, oh no, I have stream in what do you call it? In 5 minutes. I have to get up, and I thought me just getting up fast made me dizzy, but with the what do you call it? The sign and symptoms following like afterwards, I was like, oh no. Oh no, but after sleeping last night, I feel better. I don't feel dizzy, thankfully. So, thank you for asking. Thank you. Belly up or belly down? Belly up. So I was sleeping in such a weird way. No, that's probably why. They have something. I'm not familiar with it, unfortunately. But you know about your vestibular system and your ears and and your position in space. I think because I was just asleep like that for like 20 minutes, I was like, oh, nice. That's okay. It's okay. I'll try not to take any more afternoon naps like that. If you sleep belly down, your neck gets stiff. Oh, brother. My teacher was so funny because how do you call it? My teacher was so funny because she's like, you know, as you sleep with your belly, like if you're a stomach sleeper, you're just like depriving your brain of oxygen, and it's like, what? And it's like, oh yeah, you're right. You know, when you bend your head up, you're cutting off circulation to your brain, and that's why some people find it faster to go to sleep if they're laying on their tummies, just because of that very reason. So, big smiley emoji. Yeah, hold on, Nervy Cup. Give me one second. I have to check something. I forgot something now that I looked at something really quick, and then we'll get into it. Okay? Hold on. Hold on. New way to fall asleep faster, basically. Okay, I leave. I focus on this. Alright, gamers. 88 Quizlets! If we could even get to the halfway point, I'd be really excited. But yeah. Now that we reviewed over 40 pages, hopefully these Quizlets will relate to it. Unfortunately, this first question doesn't really relate to it too much, but let's do our best, okay? Okay. So in what type of documentation would you record the outcomes of therapy intervention? So I thought it was C. I thought it was daily encounter notes, which is what we were talking about with those soap notes and whatnot. And you would record the outcomes using the assessment. But for whatever reason, this says that it's the internment notes and just discharge summaries, which I don't have an explanation for at all. Oh, brother. Oh, brother. What is with this long booty question? Max, hi, welcome on in. Welcome. Hello. Rare Mona Emo. It was her birthday, I think, 2 days ago? Maybe it was yesterday. Shout out to Big Ham for the fix of it. I was like, oh, I think maybe Big Ham had mentioned that the birthday was yesterday. So I'm like, okay, day 2. A happy belated birthday to them. Hello. We're going over, how do you say it? We're doing some education stuff. I have my midterm tonight, so I'm kind of like, I went through all my notes, so now we're just going over through some Quizlets. But these Quizlets, they're a little ridiculous. We're just gonna read the question and we'll flip it over, okay? Under which of the following conditions would it be appropriate to provide therapy services? Brother? I'm flipping it over. Alright, when the assessment by the physician determines that the patient possesses restorative potential, okay, indicating the condition of the patient will improve materially in a reasonable and generally predictable period of time. TLDR, if they're a great candidate for conservative treatment, and if they're not, then they'll have to go the non-conservative approach, which is more in line with surgery, etc., etc. But yeah, good luck. Thank you, gamer. I'm really trying because gosh darn it. I still don't know what's gonna be on that exam until I see it, but we'll see. But yeah, thank you for joining. I appreciate it. When is it appropriate to establish a maintenance program? Ooh. Maybe these are all wordy. Maybe I don't do this. Maybe I'll eat ramen and I'll do this at the same time. Maybe. Because I feel bad if I'm not like actively like, oh, let me read all these options basically, and I flip the card. It's more just for like, hey, so I don't have to read all the options. I'll be here all day then. And I feel bad changing my mind. I did want to hold myself accountable by being like, let's get to halfway, but I'm like, gosh darn it, some of these questions like I could do. Oh, compromise. Let's get to a magic number of 15 because the later halves are true and false, and that's much easier. So we'll try. So card number 3, really quick. When is it appropriate to establish a maintenance program? So the answer was all the above. So this is really important to establish if the clinical condition requires specialized skill, knowledge, and judgment of a qualified therapist to design or establish a maintenance program related to illness and injury. When identifiable danger to the patient exists, such services are covered. I don't really get why it would include B then. Yeah, baby peeps? Okay, what happened? If the patient demonstrates a significant improvement or decline, change in the patient's condition or functional status that was not anticipated in the plan of care, which procedure should you follow? So if they have significant improvement or decline, and it was not anticipated, oh my gosh, baby. It was not anticipated, so what should you do? I would probably do C, conduct a reevaluation to create new goals for the patient. Thank you. So yeah, there's a dramatic change, it only makes sense. Alright, if the patient completely fails to respond to therapeutic interventions outlined in the plan of care that requires a complete change of services, what procedures should you follow? So if they fail to respond to the intervention, what should we do? What happened? What happened? You hate. She's so cute. Well, we want to do A. Would we do B? Amend your documentation? That requires a complete change of services. Part of me is like, reevaluate. But if you have to do a whole change of services, would you just amend them? No. No! Always reevaluate! Maganga! Max, thank you so very much for the follow. Welcome to the Cup Club. Welcome. One day I won't be studying. One day you'll see me actually gaming. Christ. Anyway, true or false? Therapy assistants may not make clinical judgments about why progress or was not made, but may report the progress objectively. True? Okay, so that's just a more distinguishment between an actual therapist and the assistant. They can make reports, but they can't really make the assessment quite yet. All the reassessment would be through the main therapist themselves, okay? Cat Cam, yeah! Cat Cam! She's looking out the window longingly. So cute. Alright, true or false? Therapy assistants may write up the progress report on a patient as long as the clinician writes up the next progress report. No? False? Yeah, therapist assistants can't make notes. True or false? Clinical justification means that the documentation clearly Clinical justification means the documentation clearly demonstrates the skills of a clinician are required to safely and effectively perform the intervention. Yes? True? Yeah! I'm like, It's like, yes, would you safely and effectively perform this and show that you demonstrated it through documentation? Yeah, I would. Alright. When should discharge planning begin? During the evaluation? Yeah, during the evaluation. I'm not going to read the other options. So, it's the idea of when you do see a patient for the first time, your number one goal is how can we get them discharged? And it's not to rush them. It's not like a mean or rude thing. We're not trying to rush them, but where can we go with our plan? What kind of goals can we make so we can discharge you? Because the goal again is to reach their like how do you say it? Not their prior level of function, but basically to maximize their function. And so that's why planning should begin on basically day one. Fabio. Alright. Card number 10. Which information is not required to determine the appropriate post-discharge destination for the patient? What is not required? How the patient will pick up their prescription meds? Yeah. Everything else should be required, so we have to know what is required for a smooth transition. We should consider some of their social and physical factors, of course, and understand about the community-based support services that the patient may have. Card number 11. If the anticipated goals for the patient have been met and the patient will not be transferred anywhere, what is the appropriate action to take? If they've been met, not gonna be transferred anywhere. Would you just continue? They have been met. Would you just discharge them? Or would you create new sets of goals? I would probably discharge them. Yeah, okay. I'm like, ah. Card number 12! 3 more to go. If the patient declines further care and is unable to progress or no longer benefits from therapy services, what's appropriate? Discharge the patient! Or sorry, discontinue PT services. What is the difference between discharge and discontinue? What? Huh? Okay, sure. Card number 13! What of the following is not a type of daily encounter note? A flowchart, because we saw the POMR, that's the one that was really neatly organized, but you had to write a lot. We got a SOAP note. The narrative is the really long fluffy one. A flowchart was not discussed. Card number 14! Which of the following is a benefit to documenting by CPT code in the daily encounter notes? Which of the following is a benefit for documenting by CPT code? B. Please? Yes. Alright, describe. So the purpose of the CPT code, remember, that's going to help us describe our service that we provide. It does not diagnose like the ICD code that we talked about earlier. And this is going to again help describe skilled interventions rendered in languages that can be easily compared with the billing claim to verify correct coding. Alright, and our last one? Yeah. Number 15. Which of the following is a mandatory requirement for documentation in the daily encounter treatment note? Alright, what is a mandatory requirement? So we saw for the Medicaid and whatnot. Let's see. Adverse reaction would be definitely number 1. Communication and consultation. Objective data. Significant changes in clinical status. That's really hard. All of them should be it, so I'm really confused of why it isn't. Huh? All these were mandatory with the Medicare requirements that we were reading about earlier. So mandatory, would you say maybe it's the objective data because it's both just what you need for billing and also for Medicaid? So C? Let's go! Alright, objective data regarding patient performance. So again, this is like the measurements with their recording of active range of motion, etc, etc. Alright, gamers. Let's go. Let's go away. Let's go eat. Let's forget the quiz that's ever existed. I think studying for 4 hours was pretty good. And I'm gonna study more. I don't think I have it in me to read 70 more cards out loud. And I'm hungry and shaky. But, gamers, please, yes. So, EP. A respectable amount? Yeah, I think 4 hours was really good, especially with a lot of that being our reading and documentation. Yeah, he's the EPS baby. And yo, guys, yes. But I want to take. I would love to afternoon nap with her right now. I can't. I gotta be responsible. Oh, no, baby piece. I gotta let go of your little paw. I don't want to let go. I don't want to let go of her little paws, but I have to. Anyway, maybe set this up, and then we'll do our little wrap-up stuff, okay? Alright, let's go over here to this window. Let us refresh. You have plenty of time to nap for her? Yeah, but still. It would have been nice. But it's okay, gamers. Alright, let's see. Alright, every come. Thank you so much for joining me today. Again, I'm really nervous because how do you say it? I have this final, so I'm really sad. Or not final, I have this midterm, and I'm not emotionally there quite yet, but it's okay, gamers. We'll definitely get to it. But with that, let us go ahead and wrap it up. I will tell you, Cubs, by tomorrow if I do stream. Again, I'll go over my spiel again with Twitter being like, oh, there's my schedule pin. I promise I'm gonna game one day, and tomorrow might be the day. Tomorrow on my Twitter, I have my schedule pin, and I wrote that I'm not streaming because I do work relatively late. But Rip did invite me to some lethal companies, so that would always be really fun, you know? Oh my goodness. But we'll see how that goes. If I do end up streaming, yay. And if I don't end up streaming, heck. But I'll be back Friday and I'll tell you, because being like, yeah, that midterm, that was something else. You would never believe. So, yay. Let's see though. Let me close this out. So many people are streaming today, gamers. I don't even know who to raid. Oh. But we'll do our best. I think I know who to raid because there's also someone who's doing a little bit of studying, so that's always really fun and exciting. So I'll stare at them and hope that they don't end stream. Plus, they're really new. I don't. Maybe I don't get to catch them because they've been streaming for 2 hours already. So I'm like, I don't think I got to raid into them. So you know, I love that for me. Yeah. Huh? Asa says, just remember to breathe, read, and read the question. I will. Ricky says it's okay to be nervous. I know, it's just because my grade depends on it. It's so stinky. Imagine things being dependent on your grade, your livelihood. Kind of stinky. Thank you, Hug. Thank you. You got this. Thank you. Rev also says you got this. I'll keep all the fingers crossed and thumb squeezed. You know, honestly, gamer, that's been working so far. Keep up the great work. And thank you, Gala. Thank you. I'll come back with a 200%. I'll definitely come back with at least a 70% or higher. I got you, Cubs. But yeah, let's go ahead and raid Hoshino. They're doing some studying right now, and they're playing a game. Oh my gosh. Sumire? This is like a visual novel. It's not a visual novel. I don't know how to explain it. I feel like I heard something about this game. I know the art style is really pretty, but Oh. Okay. Narrative adventure. Steam gives it a 10 out of 10 with 605 reviews. The only downside right now is that the person is playing in Japanese because they're trying to learn Japanese. But I'm sure with their... wait, I wonder if they're speaking... If they're translating it. Let's see.
I still kind of want to watch The Last of Us.
Yep, they're speaking in English. That's good enough for me. So even if they're studying Japanese, they're going back and forth. So yay! Yeah, gamers, feel free to join the Discord. It's the official Cup Club. I ping when I go live. Tuesdays we have anime night, and we should be starting a new series soon, so please look forward to it. We just finished Psalm 100, but we're also watching we're also watching Sign of Affection, and we're also watching Delicious in Dungeon. Gotta put a poll again to see what our fourth anime is gonna be, but it could be anywhere from Lucky Star, Melakani's Haruhi Suzumiya. It could be Banana Fish. I don't think I'm gonna put One Piece up there because I think One Piece is gonna take us 500 years, but one day I will get into One Piece. One day. But yeah, with that as well, please feel free to check out the Twitter. I have my schedule pinned up. Again, I might stream tomorrow. But if I don't get to catch you, Cubs, I'll definitely catch you Friday. But if I don't catch you anytime then, please enjoy the rest of your week and have a good weekend. I should be back Friday officially if I don't stream tomorrow at 12 p.m. EST for more studying. But it won't be studying like this. It will be our co-working Pomodoro session. So look forward to it because I got some work to do still. I haven't done any of my assignments this week because I just need this one thing done. But if tomorrow doesn't happen, we'll eat the company and I get really motivated to do my assignments, maybe Friday could be a gaming day, so please look forward to it, okay? But next week, not gonna be any easier. Next week will be more interesting though, and I will have more of a passion of talking about stuff, gamers. But we will be talking more about the spine and the cardiac, the heart. Just because Tuesday is my cardiac exam, and then Thursday is my spine course, so that's going to be my main focus as well. We'll be back Friday, at least next week for sure. When it comes to gaming, we'll probably progress more with Tears of the Kingdom because we're almost done with that game, so I'm super duper excited. Yeah, and after midterm, so this is the week after next, we can finally start Metal Gear Solid 3 Snake Eater, so look forward to it, okay? Okay, but yeah, please feel free to check out the socials. I have my TikTok, my YouTube, and all the really cool fun stuff there, so I really appreciate it. On YouTube, I upload my VODs, and I'm trying to do really good with uploading it within the week or having it a little bit closer to a one-to-one schedule. But yeah, whoa, Tears of the Kingdom, yeah! I'm so excited, we just got our last sage. So, and we got all our memories, so right now, I'm inspired, gamer. But yeah, with that, let us go ahead and get our raid message! If you're not subscribed, absolutely no hecking worry, gamers. We are going to use the berry emoji with the Gao raid. And if you're subscribed, thank you so very much for your support. I appreciate it very much. Please feel free to use the Tipanya with the Gao raid. You can also unlock the email with channel points, so yay! Yay. But yeah, we're gonna be raiding into I want to keep saying Hoshino, but maybe... Hold on. Do they not have a Twitter? Wait, they do. They have a link tree. I'm like, let me see what their preferred name is. Hold on. They don't tell me. Oh, Mitsuki. Alright, we're reading to Mitsuki. He's playing Sumire, which is, again, interactive. Really pretty, like, game. I don't know the premise of it. I didn't get myself spoiled with that. But, they're learning... Ricky, thank you. They're learning what do you call it, Japanese as well. So if you like learning from here and want to absorb knowledge like a sponge, gamer, I can't believe you're all gonna learn some Japanese vocabulary. Yay! But yeah, I will see you Cubs later. So have a good rest of your week. Make sure to eat something super duper yummy if it's lunchtime or dinner time for you Cubs. And I catch you next time. Okay? Lots of love. Okay? Bye. Bye. Baby peace is sleep that way. Bye. Alright, Ali.